Hello. So on my count,
Yes.
3, 2, 1. Please start, sir. We are live.
Hello. Good morning, everyone, and a very, very warm welcome on this wet Sunday. As I just spoke to Dr. Manisa, he said it's not wet, it's a romantic Sunday. So, very good morning to everyone, and it's a pleasure to welcome you all to our very special webinar on future trends in the management of head and neck cancers. To do the welcome and introduction, let me have a pleasure to welcome Dr. Vikas Salveja, consultant medical oncology at Regency Hospital, Kanpur. Good morning, Dr. Vikas. Over to you for your introduction, and then we take the proceedings further. Over to you.
Thank you, Team Horizon, and welcome everybody. Sorry to bother you on a Sunday morning. Yes, it is a romantic morning. It's a sunny day, and with the sunny prospects, we welcome everybody. It is important that head neck cancers has been a major part, one of the most morbid and mortality cancers in India. And the biology and the treatment is quite different as we manage in the West. And therefore, it merits a unique discussion across the globe for the same. And that's why we are here for this future trends in head neck oncology. I really like to thank every faculty, every delegate who has taken time from their leisure Sunday or a working Sunday for this conference, and especially Dr. Kumar Prabhash and Dr. Sapna Nangia for being the important integral part of the scientific committee. Without further ado, I would like to invite the first speaker for the day, Dr. Manish Singhal, for the session sponsored by the Biocon. Dr. Manish Singhal needs no introduction. He's the medical oncologist at Delhi Apollo and has a unique experience for more than a decade or more than 2 decades, and has been a teacher and guiding and lighting force for every one of us. The topic will be the optimizing treatment outcomes in locally advanced head neck squamous cell cancer, Indian patient data. Dr. Manish Singhal, be our shining star today.
Right. Thank you, Dr. Vikas, for that kind introduction, and a very happy Sunday to everybody. So, can I request the slides to be projected from the organizer's side? Yeah. So I'll be speaking on the Indian data and the optimizing outcomes in locally advanced squamous cell carcinoma of the head and neck, and to see what we have been able to achieve, and how the treatment of locally advanced squamous cell carcinoma of the head and neck has actually evolved as far as this part of the subcontinent is concerned. And although this data is small and is a parthed into various subsets or various places in the country, the data looks small, but yet it also perhaps represents that how these patients can be treated, and how nimotuzumab has been brought into the armamentarium, and what has led to improved outcomes is in comparison to the otherwise a standard of care treatment, which was chemotherapy and radiation therapy in locally advanced. So next slide, please. Next slide. So the next slide also. So this is one study, which is the use of nimotuzumab with intensity modulated radiation in unresectable and platinum ineligible locally advanced head and neck cancer patients. So this was a study done by Dr. Srinivas, and it included almost 21 patients. And mind you, these are patients which are unresectable and platinum ineligible. Next slide. So looking at the use of nimotuzumab in a otherwise platinum ineligible unresectable patient, the complete response rate which were achieved by the use of nimotuzumab given weekly for 6 doses along with radiation therapy was complete response of 76% and a partial remission of 9.5%. and a stable disease of 4.8%, with progressive disease seen in less than 10% patients. The median overall survival in this particular study was 21 months, which I think is quite good, with a 1-year survival rate of 63%. And as a matter of fact, the adverse events was not grade 3 or grade 4, which we usually see with chemoradiotherapy. Next slide, please. So in conclusion, the nimotuzumab and IMRT achieved a very promising clinical outcome in unresectable, locally advanced squamous cell carcinoma of the head and neck. Next slide. Another set of study with, again, small study, but again, it is vindicating that that the same outcome is achievable in patients who are eligible for going for concurrent chemoradiotherapy, and when nimotuzumab is added to it. The hospital records, this was a retrospective analysis of 24 patients. Next slide. Next slide. Yeah. So again, the complete response rate is hovering around 60%, the partial response rates of 4.35%, with an overall response rate of 65% and the clinical benefit rate of almost 100%. There's hardly any patients who are who had progressive disease, which was around 10% with nimotuzumab and chemotherapy alone in the previous study. But over here, we are using chemoradiotherapy plus nimotuzumab. So a very good clinical benefit rate with a good complete remission rate and a median overall survival, which is reaching almost 57 months. This sounds to be too good, but then this is how the data, the retrospective analysis is fraught with some problems. So, and it's very difficult to see that what is the added advantage of one drug in a non-randomized study, but we have the randomized study which has corroborated these findings. Next slide, please. So there is incremental benefit, and the study concluded that the combination of nimotuzumab with CCRT is doable with no major increase in adverse events. Next slide. So this is another retrospective analysis by Dr. AVS Suresh, and next slide. So this is a comparison of nimotuzumab, retrospective comparison of nimotuzumab versus chemotherapy in locally advanced head and neck cancers receiving concurrent radiotherapy. Next slide. Next slide, please. Yeah. So again, in comparison to cisplatin RT versus nimotuzumab RT, one can see that the CR rate was better. So was the overall survival, which was 32.4 months versus 26.6 months, with a good quality of life parameter also. Next slide. So the study concluded that significant improvement in quality of life by replacing nimotuzumab with replacing cisplatin with nimotuzumab. So this is a retrospective analysis. We can't really take a very strong take-home message from this particular study, but it does suggest that nimotuzumab has a significant role to play, and perhaps patients who are cisplatin ineligible, we can think of using nimotuzumab and radiation therapy. Next slide. So this is another safety and efficacy study of chemoradiotherapy with or without nimotuzumab. It's a prospective comparison called as the ESCOT-N study. And this was compared in about total of 30 patients, nimotuzumab plus CTRT versus CTRT alone. Next slide. Next slide. Again, the dose of nimotuzumab is 200 milligram every week for 6 weeks. Next slide. Next slide. So in comparison to chemoradiotherapy versus chemoradiotherapy, the disease control rate, which is overall response rate, was around 53% versus 21% in this set of patients. And the progressive disease was slightly higher, but if you look at the median overall survival, it was improved from 27 months to 33 months. And the adverse events are listed over here. Next slide. Yeah. So the addition of nimotuzumab showed definitely improved tumor response rates, which increased from 21% to 53% in this set of patients. Next slide. Now, another study by Dr. Shyamji Rawat is that nimotuzumab and concurrent chemoradiotherapy. in locally advanced head and neck cancers, which are unresectable. Next slide. So this is a single arm study, and it showed that complete response rate is around 66%. Partial response rates are around 30%. There's hardly any progressive diseases. And the 1 year overall survival is almost 100%, and 2 year is 72.9%. And the toxicity doesn't seem to have increased by the addition of nimotuzumab. Next slide. So another study by Dr. Ankur Bahl, and this is again a single arm study of 35 patients, nimotuzumab, cisplatin, and radiotherapy. Next slide. And their primary endpoint was overall response rates. Next slide, please. Next slide. Yeah, and again, their complete response rate is 48%, partial response is 48%. So almost in excess of 90% patients have some form of response, and their 1 year survival was 90%, and the relapse-free survival at 1.5 years was around 45%. So again, it is highlighting that there is the chemoradiation and nimotuzumab is a safe and efficacious option in these patients. Next slide, please. So again, a retrospective analysis from Dr. Karandikar, and again highlighting it was presented at the ASCO annual meeting also. Next slide. And showed that in 16 patients where they could treat these patients with a combination of chemoradiotherapy and nimotuzumab, the CR rate was 75%, and the disease control rate was 81%. Next slide. So again, another study by Dr. Katie Bhomik of 17 patients. Next slide. And the results concluded that if you combine cisplatin with nimotuzumab, you can achieve a good objective response rate in about 76%, with a significant number of patients achieving a complete remission. And the toxicity is within safe limits and well tolerated. Next slide. So this is the same study which has been represented again. Next slide. So another study from Dr. Asim Rai Bhatnagar, 56 patients, and again combining nimotuzumab with chemoradiation versus chemoradiation alone. Next slide. And showed that the treatment lasted about 7 cycles on weekly nimotuzumab for 200 milligram weekly into 7 doses. The overall response rate was 96% versus 72% in chemoradiation alone. So certainly there is increase in the response rates by adding nimotuzumab. Next slide. Next slide, please. So another study of 57 patients by Dr. Naresh Somani from Jaipur. Next slide. And the study showed that 6 weeks of cisplatin along with nimotuzumab for 6 weeks and radiation therapy resulted into a complete remission rate of 60%, partial remission of 21%, and overall response rate was about 81%. So in excess of 90% patient had a clinical benefit rate. Next slide. Another 11 patient study from Dr. Amit Kumar. Next slide. And this study also showed that 6 weeks of cisplatin along with nimotuzumab and radiation therapy resulted into a CR rate of around 60% and a clinical overall response rate of about 90%. Next slide. 25 patient study from Dr. Kaustav. Next slide. And again, the study showed that if you combine nimotuzumab with radiation in patients who are not fit for surgery, not fit for chemotherapy, you can actually achieve a good clinical control rate of around 72%, with only 8% having a disease progression. So if you recall the first study, it also said that about if you are using nimotuzumab plus radiation without chemotherapy, there is around 8 to 10%, in less than 10% patient who will have progressive disease, but 90% patient will have a clinical benefit rate. Next slide. So another 23 patient study from Dr. Satish Srinivas. Next slide. Again, those patients who are unfit for chemotherapy unfit for surgery and they receive radiation, the clinical benefit rate or the overall response rate is in excess of 75%, 78%, and a clinical benefit rate reaching almost 90%. Again, so highlighting that all these studies are basically vocalizing the same outcome. Next slide. So this is my last slide. And so put together, I think very small studies, agreeably, not very large studies, but put together all this data and the phase 3 trial of nimotuzumab has made nimotuzumab one of the frontline options for those patients who can afford it. And so preferably it should be combined with chemotherapy and radiotherapy so as to get the best possible outcomes. But in case the patient is unfit for chemotherapy, a nimotuzumab radiation therapy definitely offers a better outcome as compared to radiation alone. With that, thank you, and over to the organizers.
So thank you so very much for such a brilliant presentation. I hope there are a lot of faculties there. Any questions for Dr. Manish? So because we are well in time, if no, let's move forward. And it's a pleasure to welcome our next speaker, Professor Richa Vash. Hello, good morning, ma'am. Dr. Richa Vash is a consultant surgical oncologist at the prestigious Tata Memorial Center, Mumbai, in Head and Neck Oncology Department. Hello, good morning, ma'am. Can you hear us?
Yes, I can. Am I audible?
Yes, you're absolutely audible. And ma'am is going to speak on minimally invasive surgery in head and neck cancers, present status and challenges. So over to you, ma'am.
Is my screen visible?
Yes, ma'am. You can make it slideshow and all yours.
Okay. Is it seen in the slideshow mode now?
Not yet.
Okay. I think it's not showing up in the slideshow mode, so I just continue with the default mode. Okay, at the outset of the presentation, I would like to thank the organizing committee for giving me this opportunity to present. And my talk today is on minimally invasive surgery in head and neck cancer, present status and challenges. Now, minimally invasive surgery or more conservative surgery is quite a successful approach when it comes to other sites of cancer. When like we have moved from the radical breast surgery to breast conservative surgery, when it comes to abdomen, where we have moved from the open approach to the laparoscopic approach, or when it comes to prostate, where we have again moved from the open to the robotic approach with good oncologic and functional outcome. So it's a very appealing concept when it comes to the head and neck cancer, because the anatomy, which is so complicated, the location of the tumor, making them inaccessible to the open approach at times, and associated morbidity and impaired functional outcome with the open approach. So it's a very appealing concept in head and neck cancer, and various minimally invasive surgery that are being done in head and neck cancer are endoscopic endonasal skull-based surgery, transoral robotic surgery, transoral laser microsurgery, robotic and endoscopic thyroidectomy, and these are the minimally invasive surgeries that I would be covering in my subsequent slides. Okay, so to begin with, endoscopic endonasal skull-based surgery, it has been there for more than 2 decades now. It was started basically for the paranasal sinus surgery, which was later extended to the intracranial tumors like pituitary adenoma. It has very obvious advantage that it gives direct anatomical access to intracranial, nasal and paranasal lesions. It decreases the morbidity and mortality and has better cosmetic outcomes because it avoids the skin incision, facial bone flap, craniotomy and brain retraction. And it decreases the hospital stay and consequently it is more cost-effective approach. There has been a boom in this approach in last few years because of the recent technical advances in terms of better angle scopes, high definition monitors, frameless navigating system, high resolution imaging. better reconstruction, so the difficult and complex defects can be reconstructed better by the PRST, and better techniques to repair the CSF leak, like various glues, Thistle glue, fibrin glue, which has now come into being. Now, this subsite has varied histology, and to cover each and every histology would be extremely difficult. This is just to give a snapshot, which is in cases of esthesioneuroblastoma, just to make the point. This is a meta-analysis of 23 studies, which had 361 patients. And it showed that endoscopic surgery produced better survival rates than open surgery, which was significantly better. But another important result of this study was that there was a significant difference in Kaddish tumor distribution between all the 4 groups, between the study group, which was again statistically significant. So the right conclusion from this study would be that endoscopic surgery produced better survival rates in selected cohort of patients. There is no randomized evidence comparing the 2 modalities head-on. Now, this is a recently published propensity score meta-analysis of endoscopic and open approach in the malignant paranasal and anterior skull-base tumors, which comprises of 124 patients, of which 82 underwent endoscopic surgery and 42 open approach. When they looked at the whole cohort, the 3-year overall survival rate was 86% and disease-free survival rate was 74%. When they compared the survival between the 2 modalities, the endoscopic approach had a significantly better disease-free survival and overall survival when no adjustment was made. But when they made the adjustment for various factors that were different in the 2 groups, this survival difference was lost, and the right conclusion was that with the 2 approaches, there is a similar disease-free estimate and overall survival estimate. In addition to the survival outcome, this study also reported that the 2 modalities have a similar complication rate. And another 2 important points that were borne out by this study was that the wound infection rate was significantly lower with the endoscopic approach, and the hospital stay was shorter. So there was a benefit of the endoscopic approach over the open approach. Again, this study emphasized that when we looked at the tumor T stage, there was a significant difference, with the early tumor more common in endoscopic approach. So a right selection is a must for the optimal outcome. Now, this study looked at the quality of life after the transnasal endoscopic and open skull-base tumor resection, which comprised of 78 patients, of which 41 underwent expanded endoscopic approach and 37 underwent subcranial approach. And this study showed, in terms of physical function and in terms of impact on emotion, open approach had a better outcome compared to the endoscopic approach. So better quality of life with open approach in certain domains. Now, it is very important to understand, just because it has a good oncologic outcome, good functional outcome, good quality of life, does not mean that we extend it to all the patients. So these are the absolute contraindication to the endoscopic approach. If the tumor is very extensive, involving the surrounding structure which cannot be cleared endoscopically, this approach cannot be performed alone. However, it may be of assistance to look at the nook and corners and ensure that the disease has been cleared completely. Now, another concept is a cost effectiveness. And when we look at the cost effectiveness of endoscopic approach, again, limited data, and this is mainly from the olfactory group meningioma. So this is a cost effective approach, but it comes with a caveat. It remains cost effective if the cerebrospinal fluid rate is below 60% and gross tumor resection rate is above 25%. So again, 2 important points which can be emphasized here is that right patient selection and the surgeon expertise. So if we look at this study, the limitations of the open approach, the limitation of the endoscopic approach would be that there is a lack of randomized control trial to establish the oncologic safety of endoscopic approach. It is applicable only to the right cohort of patients with optimal outcomes. It has a steep learning curve and it varies with the expertise of the surgeon, and there is a need for the infrastructure. Now, coming on to the second minimally invasive approach followed in head and neck cancer, which is transoral robotic surgery. I would not go in great detail of transoral robotic surgery because we have an interesting debate by 2 of my seniors, Dr. Mudit and Dr. Shamit, which is going to be there. An interesting debate, and of course, it will be covered in great detail. But even my talk would be incomplete if I don't touch upon this aspect. So just in short, I would cover it here. Now, the concept of the transoral robotic surgery came into being once we had the epidemic of the HPV-associated oropharyngeal cancer in the West. So there was an increase in incidence, and this is a landmark study which showed that it has the HPV-associated oropharyngeal cancers have better outcome compared to the HPV-negative oropharyngeal cancer. The standard of treatment for the oropharyngeal cancer was chemoradiotherapy, and we all were aware that it is associated with the toxicity. So In light of these two facts, it was proposed that in HPV-associated cancer, there could be a role of intensification of the treatment, which would not compromise the oncologic outcomes, but would limit the toxicity. And that is how the TORS was proposed in HPV-associated oropharyngeal cancer. Now, we don't have a phase 3 data to support the role of TORS in this cancer, but we do have certain trials. So this is ORATOR, which was a phase 2 randomized control trial published in National Oncology in 2019, which had the cohort of T1, T2, N0 to N2 oropharyngeal cancer. And these patients were randomized either to the radiotherapy or chemoradiotherapy arm or TORS plus the neck dissection arm. The primary endpoint of this trial was swallowing related quality of life at 1 year, which was established using MD Anderson Dysphagia Inventory Score. Now, this was the patient accrual. So 68 patients recruited, 31 allocated to each arm. Now, important point here to notice is that if you look at the TORS and neck dissection group, only 1/3 of the patient received unimodality treatment, and about 1/3 of the patient actually ended up receiving trimodality treatment. Now, this is a demographic cohort of the two groups, and 88% of these tumors were P16 positive. Most of the tumors were T2, and more common were N2 neck status. When they looked at the oncologic outcomes at the follow-up of 25 months, the overall survival and progression-free survival was similar in two cohorts. But that was not the primary endpoint of this trial. So under part to answer that question, when they looked at the MD Anderson Dysphagia Inventory Score in terms of the global and emotional domain, the radiotherapy group was significantly better compared to the TORS group. But there is a caveat in this. It was defined that for the clinically meaningful decline, there should be a difference of 10 points, which was not there at that point in time. Now, in Jan 2022, this group has published the long-term outcome of the ORATOR trial at a median follow-up of 45 months. And again, if we look at the Maradi scores, in terms of emotional, physical, total, and composite scores, the radiotherapy arm did better, significantly better compared to the TORS arm. It was, when longitudinally followed up, the difference was there at all point in time. But again, important to note that it was never a clinically meaningful change as defined by the investigators initially, which should have been a 10-point change. When they looked at the adverse event, there was specific adverse events specific to each arm. Radiotherapy was more commonly associated with constipation, hearing loss, neutropenia, and tinnitus, whereas TORS was more commonly associated with cough, pain, trismus, and weakness. So each has its own adverse events. Now, this is another landmark trial, which was published in October 2021. Now, this is also a phase 2 trial, ECOG Egrin 3311. And this trial was basically conducted to assess the feasibility of accrual of these patients for minimally invasive surgery, both TORS and TLM. And the primary endpoint, other primary endpoint of the trial was progression-free survival. Now, this trial accrued 519 patients of oropharyngeal cancer, and these were stage 3 and stage 4 according to AJCC 7. Out of which only 359 were eligible for analysis. And these patients were stratified based on the pathological factors into low risk if they had clear margin, no node or single node metastasis, or no extranodal extension. And 38 of these patients were offered observation. Second group was the intermediate group, which comprised of a clear or close margin with 2 to 4 nodes that were metastatic and an extranodal extension that was less than or equal to 1 millimeter. These patients were stratified by the smoking history, and then they were randomized to either receive 50 gray arm, 50 gray in arm B, and 60 gray in arm C. And the fourth arm was a high-risk group, which comprised of positive margin, NET stage with more than 4 metastatic node, or ENE, which was more than 1 millimeter, and these patients were offered chemoradiotherapy. In terms of the oncologic outcomes, the 2-year progression-free survival and overall survival was similar in all the 4 groups. But in terms of toxicity, the arm B had the maximum toxicity in terms of grade 3, 4, and 5, as seen in the last table. The grade 3 toxicity was higher in arm C compared to arm B. So when the exploratory analysis was performed, it was seen that there was a significant difference in the toxicity between arm B and arm C. So 50 gray has a lesser toxicity compared to 60 grays. Between arm D and arm B, 50 gray versus chemoradiotherapy, again, arm B has a lesser toxicity. And arm C and arm D, that is 60 gray versus chemoradiotherapy, 60 gray has a lesser toxicity. So therefore, decreasing the radiotherapy dose definitely had a decrease in the toxicity. When these patients were followed up longitudinally for quality of life and swallowing scores, there was improvement in the swallowing scores, in these scores from A to C, and they were restored to baseline. But in cohort D or in arm D, it was never restored to baseline and it was always slightly poorer. When they followed up for the PAC head neck total score from baseline to 6 months for the quality of life, it was seen that in arm B and arm C, 56% of the patient had either the stable or improved score compared to only 38% in arm D, and this difference was statistically significant. Coming on to the cost effectiveness of transfemoral robotic surgery in this cohort of patients. So again, it is a cost effective procedure, but it also comes with a caveat. If you carefully look at it, in two-way sensitivity analysis, with decreasing adjuvant therapy for TORS and decreasing concurrent chemoradiotherapy for radiotherapy, TORS is decreasingly cost effective. So again, it emphasizes on the need of the right patient selection and the need of the expertise of the surgeon so that it doesn't become a tri or a bi-modality instead of a unimodality. Now, just to understand in context of India, do we really need TORS in our cohort of patients? So we predominantly see HPV negative cancer. As we see, only 20% of our population was P16 positive, and there was no survival difference when it came to P16 positive and negative cancer. And this is a publication from Tata Memorial Hospital. It also showed that 80% of our oropharyngeal cancers were actually tobacco users. So is it really relevant in our cohort of patients? In HPV negative cancer, we have shown a great tolerance when it comes to the margin. We have accepted 3, 2, even 1 millimeter as adequate in some studies. But is it okay if we accept it for the HPV negative tumors, which is predominantly our population? There is no reason to believe that anything less than 5 millimeters should do in HPV negative tumors. And if we really try to achieve 5 or more margins, which is defined as adequate in head and neck cancer, just imagine we would end up excising the superior constrictor and some other vital structures in the bed of the tonsil for the tonsillar cancer. So is it really relevant in our cohort and should it be offered to all the patients? So is it that we are hitting every nail with the same hammer because we have a hammer in hand? Or should we be more clear about where to use it? Now, coming on to the limitations of this approach, we have a preliminary data, only a phase 2 randomized control trial to support some role. And this is predominantly from HPV-associated oropharyngeal cancer. And about a third of these patients will actually end up receiving a tri-modality treatment with this approach. And it limits the toxicity if we decrease the radiotherapy dose. But if we look at the functional outcomes in terms of Madadi score, it doesn't favor TORS over chemoradiotherapy. Now, coming on to the third minimally invasive approach, which is transoral laser microsurgery. So it's a magic wand. Of course, many of our centers actually have it. It's a single-step procedure. It has good voice outcomes. It is relatively inexpensive, but it also has its own limitation, like it requires expertise and it may not be available everywhere. Now, this is a table, if you look at, it's the glottic cancers T1 and T2, and it talks about the oncologic outcomes comparing the radiotherapy and the transoral laser surgery. So in terms of overall survival, disease-specific survival, and larynx preservation rate, the transoral laser surgery seems to do better. In terms of local control, both the modalities were similar. So transoral laser surgery definitely has the advantage of preserving the larynx.
Dr. Richa, ma'am, sorry to interrupt, but you have last 3 minutes to conclude, please.
Yeah, sure. When we look at the functional outcomes, it is a cost-effective modality. In terms of the functional outcomes, the voice handicap index are similar in with the two modalities. It is also a feasible approach when it comes to radio recurrent tumor, and the larynx preservation rate can be around 72%. So it is a feasible approach in radio recurrent tumor. We don't have a randomized evidence, and this is one of the trials that tried to look at the head-on comparison in the early laryngeal cancer, and it was prematurely terminated as because of the slow accrual, because of various logistic reasons, and the lack of rationale which was accepted by the surgeon. So with this modality, the limitations are lack of randomized evidence, there is a learning curve and infrastructure, and optimal outcomes only in right selection of cases. So we have evidence in glottic cancer, but not in supraglottic and hypopharyngeal cancer. There is no robust data, or the data is limited. And biologically, these are different tumors. So we should not extend this approach to all the cancers, and we should be very, very selective for good optimal outcomes. And last is the minimally invasive approach in thyroid cancer. So open thyroidectomy has its own advantages, but it comes with a noticeable scar. The endoscopic thyroidectomy is better in terms of cosmetic outcomes, and robotic thyroidectomy improves it even further with a 3-dimensional visualization, limitation of the hand tremors, and fine control. These are the outcomes comparing the robotic thyroidectomy and open approach. In terms of surgery time and brain output, it is favorable with the open approach when it comes to oncology clearance, more nodes are harvested with the open approach and thyroglobulin levels are lower with the open approach. They have a similar complication rates between the two approaches. However, the benefit of the robotic approach is mainly cosmetic and lower levels of swallowing impairment with the robotic approach. And when we compare the endoscopic and the open approach, again, the surgery time and drain is in favor of the open approach. There is equivalence in terms of the surgical completeness. In terms, however, lesser nodes are harvested with the endoscopic approach. Complication rates again are similar, and main benefit is basically in terms of the cosmesis. But really, is it worth it? Now, this is one of the patients who has undergone surgery through the open approach, and this scar is hardly visible. So if we make a right scar with the right technique and it heals without a complication, we even have good outcomes with the open approach. Now, another important point to understand about the robotic thyroidectomy is that it is basically followed at one particular center, which is basically South Korea, and maximum number of publications are from those centers. And the main reason behind this was that there was a time when they were doing extensive ultrasound of the neck to detect the thyroid nodules, and they were detecting small incidentalomas in young females. So they had to excise, and to achieve a good cosmetic outcomes, this approach was preached. But when we look at other centers from the globe, this is the data from the United States, where only about 1% of the total thyroidectomies were performed through the robotic approach. And if you look at the trend over the period of time, there was a sharp decline from 2009 to 2011. There was a sharp rise first in the volume of the patients who were undergoing robotic thyroidectomy, and then a sharp decline because of the rise in complication and withdrawal of the technical support. And as a consequence, since the complication rate is inversely related to the volume, the complication to volume ratio increased. So higher volume center have a lesser complication rate, low volume center have a higher complication rate, and that's why high complication rate in these cases. When it comes to complication, do we really have a true picture? So this is another interesting publication by Drell in which he showed that only 1/3 of all the studies reported all needed outcomes when it comes to robotic surgery. So in only 26% of the patient, there was a preoperative laryngoscopic finding reported. No study reported the vagus nerve monitoring. Only one study reported the brachial nerve plexus monitoring. 29% of the patient studies reported postoperative laryngoscopy. No study reported postoperative brachial plexus in controls, and postoperative calcium and parathyroid hormone was reported only in quarter of the study. So if you look at the results now in the studies that reported the complication with a robotic assisted thyroidectomy, the transient hypoparathyroidism was reported as high as 36%, the vocal cord palsy in 3.9%. There was transient and permanent brachial plexus injury, transient in 0.2 and 0.4 in permanent, and tracheal injury was also reported in 0.2% of the patients. So probably it is associated with the complications, but these complications are underreported. When it comes to cost-effective analysis, it is definitely not a cost-effective modality. There is a 217% increase of cost with a robotic approach compared to the open approach. And mean operative time is 113 minutes with the open approach, which is significantly lesser compared to 137 minutes with the robotic approach. The limitations of this approach, therefore, are it is not a cost-effective procedure, practiced only at limited center, and there is a steep learning curve to it and high complication rate. So if we conclude, this is the concluding slide. So if we look at all these modalities and try to analyze them under the relevant headings of oncologic safety, functional outcome, quality of life, cost effectiveness, and cosmetic outcomes, we see that only 2 modalities are marked as yes in majority of the columns, and these are endoscopic endonasal skull-based surgery and transoral laser surgery. But we should be clear that it is with good expertise and in right selection cohort of patient and not for everyone. When it comes to TOS, the data is preliminary. It doesn't favor TOS in terms of functional outcomes, and it is cost effective only if right selection of the patient is made and they are not offered trimodality treatment. And in terms of the robotic and endoscopic thyroidectomy, the oncologic safety is questionable, although even these are good prognosis cancer. The functional outcome underreported, and probably there are more complications with robotic or endoscopic approach. It is not a cost-effective modality, and all we are offering to our patient is just a cosmesis. Thank you.
So thank you, Dr. Richa, for such a lucid presentation. Might be some questions would be there, which I'm sure Professor Alok Thakkar is going to have in the panel discussion. So we quickly move to the next topic, and this is a panel discussion. It's a pleasure to welcome Professor Alok Thakkar from All India Institute of Medical Sciences, New Delhi. Good morning to you, sir. A pleasure to have you with us to moderate a panel. By the time you adjust your slides, we have a pleasure to welcome the panelists for you. Dr. Alok Thakkar, sir, you're there?
Yes, I am here. Thank you
Yeah.
so much.
Yeah, so I will just introduce the panelist, Dr. Aseem Mishra, Associate Professor, Surgical Oncologist from Homi Bhabha Cancer Hospital, Varanasi, Dr. Rajan Bhargav from Regency Hospital, Kanpur, Dr. Rohit Tekriwal from Regency Hospital, Kanpur, Dr. Ashish Kulshrestha, he's a consultant radiation oncologist from Kanpur, and it's again a pleasure to have Dr. Vinita Goyal, Director Radiation Oncologist at Fortis Hospital, Shalimar Bagh at New Delhi. And we have Dr. Arun Chandrasekhar, Senior Consultant Medical Oncologist from Esther Malabar Institute of Medical Sciences. So good morning, everyone. Professor Thakkar, sir, over to you for your presentation. You have 30 minutes for a discussion, sir.
So thank you. This certainly is a meeting which is keeping very tightly to time. Nice. You've been quite harsh with your speakers. So I guess you can all see my slides. Can you confirm that?
Yes, sir.
Hi, Aseem.
Hello, sir.
Yes.
Hello.
Can we see the other panelists, please?
Good morning, sir.
Good morning.
Hi, Alok.
Hi, Rajan. Yes. Dr. Tekriwal.
Good morning, sir.
Morning. So good to catch up. Okay. So thank you to the Regency team and of course to Dr. Talreja for thinking of me for this endeavor. What we're going to do here in this short time that we have with us is to look at is there any way that we can have the panelists on the yeah, okay. I see most of the panelists here. So we have Dr. Aseem Mishra, Dr. Rajan Bhargav and Tekriwal, who are surgeons. We have Dr. Ashish Kulshrestha and Dr. Vinita Goyal, who are radiation oncologists. I don't quite see them here. I hope they're here.
Yes, sir.
Yeah. And we have Dr. Arun Chandrasekharan, who's a medical oncologist. And what we are going to be doing is really to look at how to apply the evidence that we have. Evidence, of course, has to be applied very carefully. And evidence-based medicine is not only just about reading the literature and applying it, but to see as to how it applies to your patient, how it applies to your practice, your expertise, your local conditions, your own situations with regard to the kind of results that you get. And then also to see as to how much of it is accepted by your patients, because ultimately it's patients who have to take these close calls between survival and organ preservation, which is really part and parcel of taking treatment calls for cancer larynx. So we move on and we'll try and discuss both issues. And let me first get on to this very basic situation, which is a patient who has a proven mid-caudal cancer, which certainly seems T1 on initial evaluation. And 57-year-old gentleman, biopsy proven. And what I'm going to ask here from Dr. Kulshrestha is really that if you have a patient like this, would you be even looking at involving a surgeon? You think there's really no need?
In early stage, there is a high chances of organ preservation is there. So I would like to prefer radiation therapy in this patient with higher mortality.
So yeah, so basically what you're saying is that this is an ideal patient for someone to be treated with radiation therapy, and you can offer both a high chance of cure and a high chance of organ preservation. Well, I would say it's almost approaching 100%, certainly exceeding 90%. You could achieve here.
More than 90%.
Yes, and in terms of technique, I mean, people are going to say that I'm going to radiate the larynx and there's so many issues with radiating. You can never radiate again. They're going to be a dry mouth forever. And
Hello.
what kinds of situation would you choose? Wherein, what kind of modality would you choose for this patient in terms of radiation? What technique?
Sir, athlete, IMRT or rapid arc or BMAT technique, this would be preferred in this patient because it's a very localized disease. We'd like to prefer treatment over this given area only.
And can you,
in early stage, there is very less chances of nodal involvements also. So IMRT or IGRT is a better approach.
Dr. Vinita, you would agree with that? What kind of technique do you prefer for these patients? Dr. Vinita, are you with us? So well, moving on from here, so I'll ask Dr. Kulshesh, what are the situations when you do want the surgeon involved? What are the situations when you aren't quite happy for a T1 cancer to treat on your own and you wish that there was a surgeon involved? Or rather, what are the patients wherein you feel?
In T1 lesion, generally we prefer radiotherapy.
Right.
If there's residual disease or any other features, then may go for the surgery.
So what you're saying is that if so, Aseem, is anterior commissure something where you think you should get involved?
Actually, this is a mid-cord lesion that we are seeing right now.
Yes.
So,
Yes, sir.
so definitely what happens is when we consider trans-oral laser microsurgery, if we find that the candidate is fit, with a good pliable mucosa, the mouth opening, the laryngoscore is good, I would definitely consider this patient for a transoral laser resection. It will hardly be a type 2 or a type 3 cordectomy, and the voice restoration and it will be very good post resection. One point I would like to add for this is if I do a transoral laser resection, my laryngeal preservation is going to be an excellent option because I'm going to preserve the larynx. If there is a recurrence, I can again redo and go in for a laser microsurgery once again. So I can reserve the radiation for later on or for a very extensive disease later on, rather than going in for a radiotherapy in the very beginning for such a cancer. Even if this tumor was exceeding or reaching up to the anterior commissure, if we are just resecting till the anterior commissure, the voice outcomes are still very good. So I would weigh the options of preserving the larynx on a long-term basis by doing a transoral laser microsurgery for this patient.
Dr. Bhargav, you agree with that?
Alok, I 100% agree with Aseem. My point nowadays is that here is a mid-caudal lesion, as Aseem has rightly pointed out, and more and more when people are coming to a private setup, they are well aware of their treatment options,
Right.
and they have read a lot about their disease process as well. So I think the three things that are very important is that what is it that the patient is also wanting? That is very important. We need to, kind of discuss threadbare with them that these are the two options, radiation and transoral laser surgery, which give fairly equal results in a T1 situation. And these are the pros and cons of each of the treatment modality. And what is it that you would prefer? Now, here is a situation where a person has to come for 6 to 7 weeks, 5 days in a week, vis-a-vis one theater visit. And if everything goes well and his tumor margins are all right, he's actually had a organ preservation and he's cured for life. Or as Aseem said, then in case the margins are also not that great, we can always go back in. So there is obviously a surgeon bias in this. But having said that, I think the option should be laid open to the patient. The tumor factors are also very important. If there is obvious anterior commissure involvement or going on to the cartilage, then they are not really important. The third thing is that here is a center like ours, which is very, very, at this point of time, kind of focused on oral cancer. And Aseem has started the program of transoral laser surgery in Varanasi. A friend of mine in Lucknow has started it. So centers which develop skills and have the instrumentation to do transoral laryngeal surgery, they can certainly take it up as a surgical exercise also.
So let me ask you, Rajan, there's so many points on which you choose which one to use, which one not to use. Some of them obviously find more resonance with patients and some of them find less resonance with patients. But what is it? What is the key on which patients seem to take their calls on whether going in? Is it cost? Is it?
Absolutely. Cost is a major consideration. If you ask Rohit, another colleague of mine, half the times we are discussing the cost that is going to be accrued by the patient and how we can support him by reducing the cost in the hospital or getting support. So it is very important that cost is a major consideration. Second consideration that comes. Yeah, sorry.
Where does laser come in when you talk about costs?
Oh, absolutely. I at this point of time, I have to, kind of to start a transoral laser surgery protocol in our hospital. I'll have to, kind of really convince and show data that I have enough amount of work to, kind of ask for a quality laser in the hospital, because that costs a crore of rupees.
So Aseem, you do have a laser, and you're talking about the issues that Rajan is telling us, that there are going to be issues with regarding to some patients needing re-resections. Is that part and parcel of your experience?
So laser resection is actually very cheap as when we compare it with the radiotherapy here. It's almost 1/3 or 1/4 the cost of radiation oncology. Plus the laryngeal preservation is definitely much more superior. So, and we have a joint clinic decision. So even our radiation oncologist prefers transoral laser surgery for such lesions. So they would not go in and straight away opt for or ask me that no, I'll radiate this patient. They always prefer, even with IMRT or IGRT, they prefer that we do a laser resection rather than take the patient for radiotherapy.
That is for a unilateral vocal fold.
Even for up till the anterior commissures, because we have some data, we have some up to around 85 patients that we have done for squamous cell carcinomas. And even in anterior commissure patients with a good speech therapy, we have a good recovery rate with voice within next 3 months.
So
first 3 months is an option, but after that, it's a very good control. So and the most important thing is the laryngeal preservation, which is definitely much superior.
I am also sure with the T1 cancer, we could be very sure on that one, that laryngeal preservation is much superior. Certainly, this has been mentioned in the literature that laryngeal supervision, that the overall organ preservation rate might be higher, because when you do salvage, then a salvage post radiation always requires a total laryngectomy, but that is also now very much under, let us say, under being re-evaluation. Certainly, T1 cancers that recur are not generally salvaged with a total laryngectomy today. But my question to you was basically with regard to when you're doing a laser resection, what do you have in mind so that you can minimize the rates of positive margins and re-resection? Because that is also very much a little bit of part and parcel of undertaking small margin laser resections. There is always a small risk of a margin positivity because you're doing small margin resections here. And the pathology of the disease does support taking small margin resections for cancer glottis with minimal margins in the region of 2 millimeters. So what do you do to minimize your positive margin rate?
So first thing is a very good evaluation of the exposure, whether I'm going to get a good exposure of the larynx. So that is a prime workup that I do, that whether the laryngoscore, if I'm having a laryngoscore of a 0 or a 1, excellent, I can expose the entire lesion properly. Another thing that we do in a pre-operative evaluation is that we do a narrowband imaging. So we evaluate whether there is any dilated arterioles around that region or what is the extent I may have to resect. So that evaluation is done, plus a good microscopic enhancement when we are suspending the larynx. So we do a good microscopic evaluation and see what is the margin that I will require. And then when I have to resect, it's clean and clear.
Yes, narrow band imaging is a play of light which focuses more on the green blue spectrum, and what you're imaging, you have better access to the submucosal vessels, and this can often lead you a little bit better assessment as to what is happening with regard to the
Yes.
extent of disease that you see. So that your surgical excision can be a little bit better, and you can ensure that your positive margin, again, well demonstrated in the literature.
Yeah.
Of course, there are many situations where laser is now not considered appropriate from the heady days of laser when it was applied to T3 and T4 tumors. But certainly for a T1 tumor and many T2 tumors, it continues to be a modality which can offer a high chance of resection, good chance of cure. These are the rates that are published from the West, probably the largest study that exists, which shows that there's hardly any difference in terms of survival with both these modalities. And as was brought out by the team at Regency, the basic advantage of undertaking the laser surgery is that it can avoid over treatment, because some treatment you don't really have to treat the whole larynx, and the plus a big advantage, it is a single surgical treatment rather than having a 7-week surgical treatment, which has indirect cost to the patient. But ultimately, it often is up to the patient to choose, as was brought out.
Alok, can I ask you a question? I'm sorry, I'm overstepping, being a panelist myself. Yeah. So what is your take, being in an academic institution, as to the learning curve of doing laser surgery for CA larynx?
So I think one has to be very careful with case selection. Certainly, the early experience has to be with benign lesions and with the early cancers. But it's not a greatly difficult skill to take up. Once you get comfortable with the general way of doing things, of course, you can move on to more challenging situations, which may be a transligamental, transmuscular, or a type 4 cotectomy, or in our practice, laser is very much part and parcel of both benign laryngeal disease and early laryngeal cancer disease. We are not so keen on it for salvage because we don't quite find that. But as I said, the learning curve is not so difficult, and you have to be sensible with how you start out.
Okay.
You shouldn't be quite doing the most difficult patients first. In terms of costing, interestingly, I know of a couple of private hospitals which find it cheaper than radiation. But of course, there's the initial capital cost. But after the initial capital cost, I was told that there are a few hospitals who choose, where patients tend to choose radiation primarily because it's cheaper than radiation. Tend to choose laser because it's primarily cheaper than radiation. And Asim seems to have a similar experience. Laser is cheaper than radiation. Because the radiotherapy machine is also has huge capital costs.
Absolutely.
So let's move on.
My put for laser surgery is not just the cost, it is also the laryngeal preservation, which we tend to oversee, because what happens is, yes, definitely there is a 90 to above up 90% cure rate with radiotherapy, but with transforaminal laser surgery, there is a similar or higher cure rates. Plus, we have a laryngeal preservation, and subsequent or recurrence also can be dealt with laser surgery.
Can
So
I make
anyone-
a bit clear?
Yes.
I have joined a little late. Dr. Thakkar, this is Dr. Vinita Goyal.
Yes, I get that, Dr. Goyal.
Yeah, hello, good morning, everyone. So,
Are you in agreement with Dr. Asim Mishra, or you find his statements too provocative?
I find them provocative. I would say that I would say this on behalf of the entire radiation oncology community, that we take pride in treating early laryngeal carcinoma patients with radiation therapy, because we know that we can provide them cure, preserve their larynx, and maintain their quality of voice as well. Now, doing radiation therapy definitely costs, and so does laser surgery cost. And I agree that there is a cost to establishing getting the equipment for radiation therapy. But fortunately, India still has a large number of cancer hospitals with dedicated radiation machines. And for doing laryngeal radiation therapy, honestly, it is not a must to have a fancy radiation therapy machine. I have worked in Patna for about 2.5 years, and we could give as good results even with telecobalt as we can do with IMRT and IGRTs. IMRT and IGRT provide a very small edge over what can be done even on telecobalt machines. So I think the cure rates, control rates, quality of voice, everything is excellent with radiation therapy. My only challenge with laser excision is, you all know it better, especially it becomes difficult to do it when the lesion is close to the anterior commissure. But the major challenge that I face is that CO2 laser is not easily available, and the operators to operate it effectively again are not easily available. While if there are 1,000 radiation oncologists in community, I am pretty sure that 1,000 out of 1,000 can do a good job of radiation therapy.
So we agree totally with what you say, that in our current it's easily available. But if you are going to be, and we very much agree with what you say, that you don't quite need a sophisticated radiation technique or machine to be delivering radiation for cancer glottis. But considering both are available, it can sometimes be difficult to choose for patients for the very good reason that both are very effective treatments, and oftentimes it's up to the patient, and it's up to other issues like the duration of treatment and the cost of treatment, on which oftentimes decisions are made, providing both are available, of course. So let's move on, because ultimately we have very little time and we have a very strict time master. So moving on, here's a patient, and Dr. Tekriwal, he comes to you at Regency Hospital.
Yeah, sure.
This is a supraglottis transglottic kind of tumor.
Yes.
And he has mild difficulty in breathing. He didn't quite get further.
Hello.
He ignored his hoarseness, symptoms that smokers.
Hello. Hello.
Hello.
Hello. Hello.
Can't hear Dr. Thakkar now.
Alok, you are somehow mute, or your.
So do you hear me now?
Yeah, it's
Yeah.
better.
Yeah.
Better.
Yeah.
So the patient is in front of you. I hope you can see my screen.
Yes.
And this is a gentleman who ignored the initial hoarseness and ignored the initial difficulty, mild difficulty in swallowing, because these are part and parcel of symptoms that smokers often have. And now that he has mild difficulty in breathing, has walked up to us.
Right. This is the most common presentation that we get in our OPD, and most of the patients usually come after an initial waiting period of 3 to 4 months. And by the time they come, already it is either late T2 or T3, maybe early T4. And the first thing that we decide or we assess is that whether we can preserve the larynx or whether we cannot. Looking at this image, we can see that the thyroid cartilage is not yet completely eroded. Only the inner, maybe there is a inner a small erosion. So this patient will be best served by concurrent chemoradiation. And maybe the newer studies that are showing the additional use of MABs. So he will be better treated in a trial where we put in MAP together with the concurrent CTRT.
So Dr.
Hello.
Chandrasekhar, similar thoughts?
So I think Dr. Tekriwal has correctly said that we try to assess whether the laryngeal framework is preserved or whether it is destroyed. If it is destroyed, which means there is a thyroid cartilage invasion or extrathyroidal extension, or if the patient is having too much of aspiration, then those are the candidates who go for surgery. But if the laryngeal framework is preserved and there is no evidence of aspiration per se, then majority of these patients have to be started on concurrent CTRT and would like to reserve surgery for any failures or salvage.
Alok, I have a small point to add, and this is because of Vikas, who is a very, very enthusiastic medical oncologist, and he keeps on troubling our colleagues, my team, for emergency tracks. So whenever we have a situation like this, I think assessment of airway so that subsequent therapy, whether it's radiation and all, whenever it leads to respiratory distress, we should be already prepared for it by doing a track early. That's one of the things, because doing it in the middle of the night is a big hassle in any setup.
So what you're saying is,
I would like to add one point in this, since you have mentioned mild difficulty in breathing since 2 weeks. So this may progress, so there may be some dysfunction.
Absolutely.
We had done one study at Tata Memorial Hospital in Mumbai for the similar lesions for organ preservation. So what alternative options we can have is giving neoadjuvant chemotherapy. I think Vikas was also the part of that study. And where we give a neoadjuvant chemotherapy in form of 100 milligram per meter square, cisplatin with paclitaxel. And subsequently, we keep the patient admitted and assess for the relief in the breathing difficulties. So usually most of the patients, almost 60% of the patient in that study had recovered from that respiratory distress and avoided a tracheostomy, and then they were treated with CTRT. So that was only in a subset of patients who were presenting with difficulty in breathing.
so
Otherwise, definitely if no, or as Dr. Vinita madam said, so if it is not involved in eroding the cartilage, definitely goes for CTRT.
Yeah.
Dr. Mishra, I'm not aware of
so what
the
Dr.
study that
Vinita
you
said was
have
absolutely.
So that's a study from Dr. Kumar Prabhash. It's a small series. So where they have given neoadjuvant chemotherapy to avoid a tracheostomy. So the patients were presenting in early stridor. Those patients were given neoadjuvant chemotherapy, and then they were subsequently treated with CTRT.
Dr. Alok sir, last 5 minutes to conclude your presentation, sir. We
Dr.
are sorry for that.
Chandrasekhar?
Hi, Dr. Arun here from Medical
Yes.
Oncology. Yeah, just about that trial. I was in Tata. It was just prior to when I joined there, but yeah, basically they looked at tracheostomy was leading to inferior overall survival in some retrospective studies. So the funda was to give induction therapy to prevent a tracheostomy. So I think total of 9 to 10 patients was the actual number. It's a very small number.
Yeah.
But the patients did have a benefit with the chemotherapy. I think they've used TPF if possible in most of the patients,
Yes.
but that had some improvement. But again, these are very small numbers. So I think if there's a delay to the start of RT or, there's because of the waiting list time and all that, definitely this is an option which we can
No,
consider.
I mean, we are not talking about delays. They don't delay at Regency Hospital. So Dr. Tekriwal, you are the primary surgeon. You had this patient, and of course, you sort of said that it seems that I can do organ preservation here. So why should I be operating on this patient? Let's look at. But as has been quite sort of brought out by Rajan and then by Aseem, is that because there is mild difficulty in breathing, you're not quite sure as to whether radiation or chemoradiation at this stage would precipitate further issues. And certainly organ preservation with a tracheostomy, it doesn't quite make too much sense to have someone with a scarred larynx and then also a tracheostomy. So now of these 4 options that you have here, which one have you chosen finally for your patient?
I still would like to go with concurrent CTRT because see the patient is having a mild difficulty. He is not having stridor at present. So I don't see an immediate threat to the respiratory tract at present.
So I think it's sometimes can be very difficult, but even if you look at how the NCCN looks at it, it can be very confusing for T3 lesions because it does seem that that everything is on. Sometimes concurrent chemotherapy, sometimes radiation alone, of course, sometimes a total laryngectomy, sometimes induction chemotherapy. So all of them are part and parcel of what is generally. Certainly, we tend to go down this road, which is the first treatment, that is the preferred treatment if feasible. But there are going to be issues when it may not be feasible or appropriate. And this one, as were laid out by Dr. Goyal, was that it may be a patient who's having a little bit of aspiration. And of course, it may be a patient who's having a little bit more respiratory distress than what perhaps this patient was happening, or maybe a patient who's otherwise not suitable for chemotherapy because of medical issues. It may be unfair to ask you to choose between these without actually having more information on the patient. But here was your patient, and Dr. Goyal did treat with radio chemo. And here was the patient 3 months, 4 months after completion of treatment. The cord is a bit mobile. There is some edema. Is this patient cured?
We need to evaluate. We need to again go for imaging, and basically first we would like to go for a CT scan and contrast enhanced CT scan. And if there is any doubt, then we might need to go for a biopsy if required. Additionally, we can consider PET-CT in this case.
So, Dr. Arun, what is your choice on follow-up for these patients? How do you follow up these patients?
Yeah, so same thing. 3 months after the end of treatment, we normally do a PET scan straight up and a local examination, send it to the surgeons, they look locally as well. If the PET scan shows CR, then that's a 3-monthly follow-up. That's what we do.
And how often do you repeat your PETs?
Oh, just the first one after 3 months. After that, we don't do it again if it is in CR. We just, clinically and clinical examination per se.
So you wait for anything to show signs of recurrence. And so last
one
question
point I would
now.
like wanted to add for this thing, which has not come. The functionality assessment needs to be done for all the T3 larynx, T3, T4 larynx that come to us. So in default, we have to assess the functionality. We do a FEAS assessment and assessment for aspiration and all. If there is a aspiration present or the FEAS, then we have a penetration aspiration scale of score of more than 6. We consider doing a total laryngectomy as compared to going in for organ preservation.
Yeah, that's agreed. We agree with that.
Alok sir, you need to conclude, please. There are 2 questions also. If we can just have the question from the chat box and then we close, sir. Over to you, Dr. Alok sir.
So let's have the questions from the chat box. Because obviously, when only a beginning on how we take calls in patients with cancer larynx. But yes, let's have the questions on the chat box. I'd be happy to see them in the chat. So there seem to be a few questions.
Sir, I can read it for you. I think there's a question from Dr. Aditi Agrawal. For cartilage erosion, what's the experience of induction and laryngeal preservation? Dr. Alok sir and the panelists, please. Dr. Alok sir, you need to take this.
Group is spared laryngectomy after neo. There is extra laryngeal spread, but no significant cartilage erosion. Then you could look at neoadjuvant chemotherapy as one of the ways of undertaking a non-surgical treatment. And other than that, the situation that was talked about, which is wherein you have a patient who otherwise seems suitable for organ preservation by chemoradiation, but wherein you can't quite move forward on that because of mild stridor. And here again, if you can use neoadjuvant chemotherapy to downstage the tumor, it might help.
Okay, so there's one more question. Inner perichondrium, minor cartilage erosion. Can we give full dose CTRT and save functional larynx? What's your take, sir?
So certainly it's not good as having no cartilage erosion, but yes, this is a situation where you can. There are many other considerations that come in, and they have been highlighted again, and that also includes the functional status of the larynx, the general health of the patient.
So last comments from you, Dr. Alok sir, and the panelists, and then please allow us to close. Over to you, Dr. Alok sir.
Well, thank you. So it is a situation wherein a lot of careful decision making in conjunction with the patient is required. But of course, the current status today is to move towards organ preservation as much as possible. Organ preservation may mean surgical organ preservation or non-surgical organ preservation. We talk a lot about non-surgical organ preservation. Surgical organ preservation is something we haven't been able to talk about even here because of the limitations of time. But that is one other aspect, and that is about surgical organ preservation, not only with the laser, but with partial laryngectomy, which I think our audience needs to be aware of. So I conclude here. Thank you.
So thank you so very much. Thank you so very much, Professor Alok Thakkar sir, and the entire esteemed panelists for a wonderful discussion and completing in time. So let's move forward, and it's a pleasure to welcome Dr. Shyam Agarwal sir, Chairman and Director, Department of Oncology, Sir Gangaram Hospital, for the next panel. So by the time you adjust the slides, can we have Dr. Shyam Agarwal's slides, please? We have a wonderful panel today. Dr. Tarachan Gupta, Senior Consultant Medical Oncology from Jaipur. We have Dr. Amit Kumar, Consultant Medical Oncologist from Patna. We have Dr. Jitin Jadhav, Senior Consultant Surgical Oncologist from Regency Hospital, Kanpur. Pleasure to have Dr. Sangeet Agrawal from Gangaram Hospital, New Delhi. Dr. Gagan Sari sir, Director Radiation Oncology from Max Super Specialty, Delhi. And of course, Dr. Aditi Agrawal, Senior Consultant Radiation Oncology from Paras Hospital, Gurgaon. So good morning, good afternoon, everyone. Dr. Shyam sir, over to you. You have the slides in front of you. You have 30 minutes to discuss, sir. Over to you, sir.
So thank you very much for the opportunity. Thank you, Vikas, for this wonderful head and neck cancer symposium that you're organizing. So our job is to focus on oral cancer, or oropharynx, and that is locally advanced. So I think we can begin, and we have an elite panel where we have all medical, surgical, and radiation oncologists. So I think we begin with the case, which is not an uncommon situation. So this is a 42-year-old male. There's a growth in the retromolar trigone, and the patient has trismus. And on examination, there is a growth involving the buccal mucosa, retromolar trigone, lower gingivobuccal sulcus. And in the neck, there are level 2-3 nodes. So I think this is a fairly common scenario in day-to-day practice. And we go to the surgeons first as to what more they want to do, what more they should be looking for. So we have Dr. Jitin Yadav to begin with. Sir, what are your thoughts, and what is to be done, in a situation like this?
Good morning, sir.
Yeah, good morning, please.
Yeah, this is a very common scenario nowadays, and we routinely see in our OPDs. In this case, I will go for the imaging also, and we will do the biopsy. And if I consider that it is involving only the neck, level 2 or 3 lymph nodes, or the growth involving retromolar trigone, I would like to see the involvement of bone also. And I think I'll go for the surgery in this case.
Okay, so once you have the information, then you will take a decision. Dr.
Yes.
Sangeet, so you are the head and neck cancer surgeon. So what more do you want in terms of node size, node involvement, or other information, please? Sangeet, are you there? Dr. Sangeet, can you unmute? Yeah.
Sir, good morning, sir.
Yes,
Sir, I will have a contrast MRI and because in your history there is a trismus without having oral submucosal fibrosis. So this is very alarming for me, because I will see on MRI that is there any lateral pterygoid or temporalis involvement in this case. Number one. Number two is the status of nodes, whether they are with the extracapsular spread or like this. So if I found pterygoid involvement in form of lateral pterygoid or temporalis, I may think about neoadjuvant chemotherapy first for 2 cycles. Otherwise, if I don't found any pterygoid involvement, then I will straightforward go for a composite resection and the neck dissection and appropriate reconstruction in this case.
Great, perfect. So any radiation oncologist, Aditi, you want to add anything here before we move on?
So just one thing, almost everything has been said, but then the laterality has to be examined properly, whether it is a lateralized lesion or it is a midline coming to the midline lesion. And secondly, whether the nodes are ipsilateral or whether they're present on the contralateral side as well. And then definitely for oral cavity, after ascertaining that it is non-metastatic, the primary treatment would be surgery. If the surgeon says that it is not resectable or it is not operable within R0 resection, then we can go ahead with neoadjuvant chemotherapy followed by assessment for resection.
Right. Gagan, any comments before I show the slides on the MR?
Sir, I agree with everything that has been said. We need to have a loco-regional assessment. Systemic assessment is also required, but I guess that goes without saying as well.
Okay, so let's next slide. So biopsy confirms it to be a squamous cell carcinoma. The next slide shows the MRI, which everybody wants to know. So there is lateral pterygoid and temporalis muscle involvement at its mandibular attachment. And in the neck, there are multiple nodes ipsilateral at level 2 and 3. So Dr. Jitin again, so now what is your thought process at this time?
In this case, sir, we would like to know about whether it is a supranose disease or infranose disease. There are few studies, mainly Chinese studies. They have evaluated based on the involvement above sigmoid notch or it is below the sigmoid notch. If it is infranose disease and there are no other contraindication, I will go for the surgery first. And if it is supranose disease, then better to go for the neoadjuvant therapy.
Okay, Dr. Sangeet, please.
Sir, actually, Dr. Jitin is right, but when we see there is lateral pterygoid or temporalis involvement, then I think this should be supranose disease, because lateral pterygoid and temporalis are both attached on the coronoid and chordalar process. So I think we should give 2 cycles of neoadjuvant first in this case. This is my thought process, because it is infratemporal fossa disease.
Okay, Aditi. Dr. Aditi, please.
Sir, ITF extension, if it is low ITF, then many surgeons do resect it upfront. So I think I would leave it to a tumor board discussion and the surgeon's decision on the resectability. My aim would be an R0 resection. So if the surgeon is comfortable in doing a low ITF resection, getting an R0 resection, I would go ahead with surgery first.
Gagan?
Sir, agreed. This is totally the surgeon's call, whether or not they can resect it. And if and I do feel that there is an inkling suspicion that there is indeed an ITF involvement, but if it is a low ITF involvement, and so perhaps we should just go for surgery composite resection. A visual examination of the MRI is needed actually.
Okay, so I think you raised the issue of PET-CT. I want to, say that. I mean, do you want to do for everybody PET-CT, or just do a chest X-ray and take a call?
These are multiple lymph nodes that are present with a locally advanced disease. Ideally, we can even an NCCT chest will do, but in the current day, somehow the practice, because of the wide availability of PET scan and also the guidelines somewhere supporting it, we use PET scan for almost every patient once we are sure that the patient is resectable.
So Sangeet, you do it?
Sir, yes, definitely. When there is multiple lymphadenopathy, I will go for a PET CT scan in every case.
Jitin?
Sir.
So depending upon the size of the lymph nodes and the level of lymph nodes, and whether it is looking like involving the skin or there is N3 disease, then we'll go for the PET CT. But routinely, we do not advise in all cases at our centers.
Dr. Aditi?
As already said, it is not like a recommendation with multiple nodes level 2, level 3, but a CT scan chest is sufficient. But most of the times, if the patient is going for surgery, a PET CT is done. That's the routine practice.
Okay, so there are issues, but then perhaps do it. So let's come to the issues relating to surgery. Next slide. So this is I've taken from one of the next slide, please. So I want the surgeons to make a comment because this is a surgical decision and a tumor board decision. Next slide, please. Yeah, next slide. Yeah, so this is I've taken from the TMH paper by Patil et al. Where they decided that these patients are technically unresectable. And Dr. Sangeet, you like to dwell on these? Peritumoral edema or tumor extending up to zygoma, peritumoral edema or tumor extending up to hyoid bone, or extension into vallicula, into high ITF. Some of the things you have already commented, but these were the reasons why the patients were not operated in the Tata Memorial study. Yeah.
Sure. Actually, these all are the indications for practically inoperable disease primarily, but we will give in these cases this particularly according to this paper there were after two cycles of NACT and the patients were operated, so they have a better survival of overall survival.
Right, we'll come to that. So, but do you agree with these?
These are in, yes, sir. Sir.
Yeah, Dr. Jitin, your comments?
Yes, sir. I agree.
Yeah, Dr. Gagan and Dr. Aditi.
Definitely, sir.
Yes, sir.
Okay, so I think so. These are some of the areas which you need to look at the MRI and discuss with the in the team regarding the decision on resectability or not resectability. So once we have decided that this is unresectable, next slide. So what next, Dr. Sangeet, in this patient?
Sir, NACT, definitely NACT. At least 2 cycles of NACT. And after
then
that,
reassess.
we will assess.
Then
we will
reassess.
Yeah. Yes, sir. We will
Dr.
reassess
Jitin?
and as much as possible, we will try
Dr.
for a
Jitin?
surgery.
Yeah, Dr. Jitin.
Yes, sir. We'll go for the NACT 2 or 3 cycles. Then we will reassess for the resectability.
So, Dr. Gagan, you agree or you want to take them up for CTRT?
No, sir. This patient would, if the surgeons think that it's borderline operable, then neoadjuvant chemotherapy is the way forward. Followed by assessment. And
Sir, I would like to make one point. So the TMH paper that we were just discussing, they probably have the largest number of patients whom they gave neoadjuvant chemotherapy, though it was a mixed bag, not just oral cavity. So what they concluded was that the benefit was up to in 40% of the patients who could achieve an R0 resection after neoadjuvant chemotherapy. And the patients who benefited were the criteria that you just mentioned. So if there is edema and not frank infiltration into the high ITF or the disease going into the posterior tongue, and it is just the edema which may have microscopic disease, those patients tend to respond better. So we'll have to see the imaging and discuss it with the surgeon, because as per my experience, almost all of the patients would progress on neoadjuvant chemotherapy and very few patients would actually benefit. So they actually lose on time in getting the definitive local treatment.
So,
Shyam, can I take that question? Because that was the data from TMH and I'm the corresponding author for that, and that's totally misrepresented. So
Go ahead.
not only we divided that edema, we divided to soft tissue being there or not. For base of tongue and valvular involvement, there was no question of edema. It was a scan and the clinical examination by the surgeon who saw it, the valvula is involved or not. For hyoid, it was MRI or CT scan which decided how far it is from the hyoid. So this was not only the edema. For the zygomatic arch, there were two groups. One was edema and second group was where the soft tissue was up to close to edema, where you didn't have at least a centimeter margin which you require. And they were the patient who went, and there was no difference between the different groups, how they benefited. So there was no group which felt that one benefited and one didn't. So that's the reason I interjected, because that was a misrepresentation of the data. And second, someone put in revised margin. Yes, it was revised margin. There was no doubt about it. Because if there was no issue of margin, where was the question of giving NACT? Because you had, what is important to distinguish, the margin that you wanted to put the knife remained the same. But that time, if you don't give NACT, you are getting margin less than 0.5 centimeter. But once you give NACT, the centimeter of the margin increases because the tumor shrinks down. But your margin, if you take 1 centimeter from the original tumor, then yes, it does get revised. Revised margin, there are 3 papers suggesting there is no difference in the local regional control. 2 coming from Tata Hospital, 1 retrospective. 1, Dr. Asim, who made the comment, he is the student of Dr. Devendra Chaukar, the phase 2 randomized trial for mandibular preservation. All the surgeons, they revised the margins. They gave NACT because mandibular could not be preserved, and after NACT it was preserved because the margin was revised. And third was from Lisa Lecitra, negative trial. They took the revised margin, a bit liberal margin, rather than a centimeter, 1.5 centimeter. And there was no difference in local regional control. My apology, I interjected in the panel discussion.
That's like, yeah, Aditi, you want to say something?
So actually, I would just want to question this to Dr. Kumar Prabhash. So we were once having a discussion with Dr. D'Cruz, and actually this point was put forward by him, that it is the patients having edema because the tumor may not shrink as we are thinking it to be. So we need some predictive markers to say which patients would actually benefit with neoadjuvant chemotherapy.
So he is one of the author in that. In fact,
Right.
Response rate, we have mentioned it. Most of the patients, they don't progress. You made a statement that most of the patient progress. Hardly any. There is n number of NACT data in head and neck cancer, including oral cavity cancer. In oral cavity cancer, NACT doesn't add life to the patient. Absolutely agreed upon. But what percentage of patient progresses? Single digit. Same number, what the number of patient progresses in breast cancer. So to say that majority of the patient progresses on NACT is a wrong statement. But I do concede a resectable patient, it doesn't add any life to the patient, and one shouldn't be using it unless you want to preserve the mandible. So yes, edema going up to zygoma is one aspect, but soft tissue going to up to zygoma is another aspect. And I concede that they are a bit different, but both of them respond. Saying that tumor doesn't respond, all the responses we documented, they were all based on CT scan. And I'll request people, whoever has used it, there are many people I see here who have used it. They can share their experiences. That is it true that majority of the patients, they don't respond? Now we have 4,000 plus patient database with all comers, all the 12 head and neck surgeon who are there at TMH, they refer it.
Dr. Tarachan, you want to make a point?
Sir, I totally agree with Kumar. We are usually doing an whatever the indication you have made, neoadjuvant chemotherapy, so that the surgical resection can be comfortable with the acceptable surgical margin. Another phase 2 trial also just came from Tata Memorial Hospital, which said that mandible preservation is also that is good, and if we give the neoadjuvant chemotherapy and local advanced disease.
Sir, I totally agree that neoadjuvant chemotherapy, when done properly, gives good response rates. The idea is that it should not be done with a sort of palliative doses, not compromise. And this is 42-year-old man. We can certainly go with the right doses and right treatment.
Okay, so it seems that in a situation like this, which is a locally advanced oral cancer, so when the surgeons and the MDT decide that the R0 resection is not possible, the way forward is neoadjuvant chemotherapy. Dr. Jitin, you concur?
Yeah, I agree, sir. NACP followed by assessment for surgery.
So, Dr. Amit, you have a point?
No, sir, completely agree. Because something 43% of the patient in the trial has undergone surgery, and the progression rate in that post-2 cycle of DCF or DC is only something in around 10%. Though few patients have stable disease too, but maximum patients have got a partial response to the neoadjuvant chemotherapy.
Okay, so I think we seem to have reached a consensus here that neoadjuvant chemotherapy in such patients should be offered for best outcomes, in the sense that if the patient becomes resectable, that is going to give them the best PFS and overall survival. Next slide. So I'll show you the slides. So coming to the chemotherapy then, what protocol, Dr. Tarachan?
Sir, we are using DCF protocol if the patient is compliant and can report any side effect if there is any. He can report in hospital or on phone also. So otherwise, so we are giving DCF. Otherwise, we are giving paclitaxel plus carboplatin.
Okay, Dr. Amit.
Yes, sir.
The issue on the DCF is the 5-FU infusion. So are you using that in day-to-day practice? What are your thoughts?
Yes, sir. If the patient is fit, we are using it in our day-to-day practice. Might be the patient may require admission for the few initial first week, or maximum patient get discharged by day 10 of our treatment.
Okay, next slide. I think that is basically on the chemotherapy. So I think both the medical oncologists feel TPF is the best. Any role for MABs? It was being discussed in the previous discussion. Any role for drugs like Erbitux or any other? You have the availability of Biomab.
So can I give can I make a small comment here, please, sir?
Yeah, please.
Sir, since the intent of this chemotherapy is neoadjuvant, where we want a response,
yes,
and this response is directly relevant to the surgery which is going to happen, which is directly relevant to the local control and treatment, then I feel that unless we are able to use the correct protocol with the correct dose, we should perhaps change the plan to something else. I mean, that is my thought. We should not be going half-hearted into the neoadjuvant chemotherapy insofar as this situation is concerned. This is my perspective. I mean, I'm open to change and discussion, but if there is anything more, but because what we are trying to do is downstage it, and unless we downstage it, we don't get any outcome. Then if we are not able to do the correct protocol, then we should perhaps not do it at all. That is my thought, sir. What do you think?
Yeah, Dr. Amit?
Yes, sir. Completely agree. We have to go aggressive in these kinds of patients. But in few patients who are borderline patients, basically regarding the operability, if there are comorbidities with the patient and we cannot able to give him full dose chemotherapy, so we may go for paclitaxel carboplatin also in these groups of patients. So we may say that is not as aggressive as the DCF protocol, but still few patients respond to paclicarbo, and if they are not responding, they may be underwent palliative further.
Yeah, Dr. Tarachan, I mean, if everything is fine, patient can afford, what is the best treatment modality for as far as chemo is concerned?
Sir, for NACT intent, we are giving DCF.
DCF. I can see Kumar. You want to make
just to comment on this,
yes.
And I understand where it is coming from. So I know that we have been taught that DCF is the best NACT, and I totally agree that when you are giving NACT in the quest of adding life, then you should give 3 drug. Like for example, you want to do laryngeal preservation, please give 3 drug preferably, but you will preserve good number of larynx with 2 drugs. You won't be compromising outcome. The same was the data from RTOG 911. It is just that you preserve more if you give 3, unless you can give CTRT. When you are giving for borderline resectable patient, your call is different. Think about, you don't want to give 3 drugs. In larynx preservation, you don't give NACT. CTRT is good. RT is very good. You have a good alternative. Now, if you're giving NACT in borderline resectable patient, for example, the patient where the tumor has gone up to hyoid. Now, if you don't do surgery, Gagan is there. Gagan, can you give a good radiotherapy to the patient of anterior 2/3 of the tongue who has gone to up to hyoid of 70 gray? I
Sir, we
hardly
can,
see.
but it's very bad, sir. The course is very
bad. So what you are giving them? You are giving them palliative RT or palliative chemotherapy to these patients. So remember, here, if you can't give 3-drug combination chemotherapy, you give 2-drug combination chemotherapy, because you have a tumor going up to around hyoid, and either you somehow do surgery, or you are giving palliative intent. Then yes, if you give whichever form of NACT, think about only 20% patient response, but they will undergo surgery, and half of them, they will survive long term. So that is where one should not be so sticky about 3-drug combination chemotherapy. If you can't give, if you can give, today also I agree, responses are far higher with them as compared to 2-drug. So in which context you give, it changes.
But sir, can I make a comment?
Go ahead.
In a situation where we are not able to give adequate doses, I mean, I'm not necessarily saying a different regimen, but not adequate doses. In that situation, we would probably risk having a progressive disease, which can be as high as 40%.
Can I interject? Can I interject? So I agree with you. I agree with you that if we think about the tongue from anterior 2/3 tongue going to up to hyoid, if I don't give adequate NACT, let's take it 30% patient progresses. Now, can I put it to you? Aditi has said she can't do surgery by and large. That's what I understand, because one has to do laryngectomy, and usually people don't prefer doing it. No. If you give PAL-RT, what percentage of people will progress?
So as far as this tongue patient is concerned, which seems to be now the focus, which is going to hyoid, it is surprising that some data coming from the Eastern countries and a little bit from our own understanding and practice, I'm going to re-emphasize little bit, but we are finding some results, some encouraging results in patients who
Put
are
some number, Gagan.
had anterior tongue. So I mean, I'm saying that
anterior 2/3 tongue going up to hyoid. I'm putting you a specific situation, and we see in the clinic.
I mean, I'm not saying going to hyoid, but I'm saying very large tongue patients who
You are saying anterior 2/3
this
tongue.
discussion is not going anywhere. So what sir, you are trying to say is that neoadjuvant chemotherapy in any form is likely to benefit a patient, even if it is a lesser number of patients. I think that is what is the basic point.
In a borderline resectable, if Aditi can operate, why oral cavity I want to give NACT? I'm planning for NACT only when Aditi says I can't operate, and those patients in our practice, almost when I send for a radiotherapy opinion, because these are the patients, for again, I will give another example. When we say high ITF is not only high ITF. If tumor is high ITF here, Aditi doesn't operate, you will give good 70 gray. But if you have high ITF here, with a buccal mucosa down, with a lymph node being level 4, and then my radiation oncologist says, and being fair, giving 70 gray from here to here.
Sir, I'm a radiation oncologist.
My apologies, Aditi. My sincere apology. My sincere apology. So now, then what to do? Then that is where, and when I'm saying in those situations, don't get fixated with 3-drug. I totally agree with you. I have to have a larynx preservation. Then Gagan can very well say, hey, if you're not giving 3-drug, let's give CTRT. Why you want to compromise everything? In that context, I'm saying, yes, if a surgeon, my surgical colleague has a chance, 20% chance to resect the oral cavity, I will give that chance, because my radiotherapy colleague is not able to give 70 gray. If my radiotherapy colleagues, I can give 70 gray, there is some meaning to it. Sorry, again, unless we talk the specific situation, we don't understand this concept, because what people do for NACT, they club everything together. But believe me, organ preservation is different, borderlines are different, unresectables are different. In borderline big volume, I have resectable patients, such a big volume that if you can't do surgery, radiotherapy 70 gray is not possible.
So Aditi,
sorry, sir, it was a long one. Sir.
No, fine. That's the idea of
Dr. Shyam, sir, you have 2 minutes to conclude.
Yeah. I think
Final 2 minutes.
late,
please.
boss. I mean, I think although we are towards the end, I think most of the crux points have been covered. Aditi, you want to make a comment?
No, sir. As far as my practice is concerned, I have frankly not seen as close to 40-50% patients having response after neoadjuvant. But for the patient that Dr. Kumar Prabhash was mentioning, yes, I agree. 70 gray giving to such a large volume disease would have a lot of toxicity, lot of morbidity, and the cure rates would not be very great. So if the patient is young, very fit, maybe I would also want to give neoadjuvant if he can benefit. But if the patient is not so fit, then I don't know whether PF or TPF should be given or not.
So Dr. Tarachan, there is a question in the chat box regarding from the surgeon himself, Dr. Jitin, a role for metronomic chemo in such a situation.
Sir, till now, we are not using neoadjuvant or metronomic chemotherapy till now, but we are waiting for the data, and if it comes, then we may think about an unfit patients, but not now at present.
Kumar,
So if patient is unresectable and not fit for RT,
yes,
and not able to take the palliative chemotherapy, then we are giving metronomic.
Yeah, we got it. Dr. Kumar?
Sir, I agree with Tarachan, because if the patient is not fit for any IV chemotherapy, most likely is not fit for 70 gray, and then giving NACT, or not fit for surgery, most likely patient. So then, giving metronomic as neoadjuvant is a issue. Better give some, if a small tumor, better give some good palliation with 40-50 gray of radiotherapy. Keep your drug for palliation. But I do have patients who have refused RT. Then in those situations, we have given metronomic chemotherapy, because it gives you good palliation, especially the triple metronomic. Double, you can use it. It's good. Responses are good, not excellent. But triple, I assure you, please use it in 10 patients. You'll realize that majority, they do have some shrinkage. Yeah.
Okay, I think there's a comment from Dr. Anubha in the chat box saying that she has used a modified DCF, not 96 hours, but 46 hours 5-FU infusion, and given a 2 weeks interval with good outcomes. So I think we're coming to the end of this discussion. So it seems that the 3-drug combination is the ideal thing to do in the neoadjuvant setting for a borderline resectable or a potentially resectable orobuccal mucosa cancer, and the patient gets the best outcome with the surgery, and CTRT gives you certainly, upfront CTRT gives you inferior results. So I think with these comments, thank you very much. It was very interactive. Thanks to the surgeons, to the radiation oncologists, and to the medical oncologists for this interactive session. Thank you very much.
Thank you very much, Dr. Shyam sir, and all the esteemed panelists for the brilliant discussions. Now we move forward, and I think it's a very, very interesting debate that sits on robotic cancer in oropharyngeal cancer. So we have a pleasure to welcome and invite Dr. Mudit Agrawal. Sir is unit head and senior consultant head and neck surgeon at the prestigious Rajiv Gandhi Cancer Institute and Research Center at New Delhi. Hello, good afternoon, Dr. Mudit sir. And and we have Dr. Shamit Chopra, Chair Department of Head and Neck Surgery and HNMTT leader, Program Director, Fellowship in Head and Neck Surgery, Director at Patel Hospital from Jalandhar. Hello, good afternoon, Dr. Shamit sir, as well. So as we have a debate, robotic cancer in oropharyngeal cancer, hope or hype. So first we invite Dr. Mudit Agrawal for hope. I think we have Dr. Mudit's presentation. Can we request the team to play, please?
Thank you, Vikas. Good afternoon, friends. I thank Dr. Talreja and his team for organizing such a meeting, and it is my privilege to be a part of this debate. So I will be talking on robotic surgery in oropharyngeal cancer, that is TORS, is it a hope or hype? I will be talking on the hope part. I think it's a well-established thing. And now coming to the evolution of the treatment for oropharynx, if you see before 2002, before Parson presented his published his literature on whether radiation or surgery should be done as a treatment for oropharynx, and he found that functional consequences are much better as compared to when surgery was done. And then after that, the standard of care became radiation therapy. And in due course of time, in 2003-4, the chemotherapy also came, IMRT came in, and there were certain evolution in minimally invasive surgery, like in transoral laser surgery for management, but it got restricted to some few centers in the world, but it was being done. And in due course of time, chemoradiation became a standard of care in management of oropharyngeal cancers. And then it was found that there was some increased toxicity with this treatment, and swallowing difficulty and pectin dependence were there. And TORS, that is transoral robotic surgery, got FDA approval in 2009, and it came into picture. So other landmark thing which happened was knowing that HPV status role in management of oropharyngeal cancers. And it was the landmark paper from Kian Heng, which showed that patient with HPV positive had much better prognosis compared to HPV negative. So now coming to the latest guidelines which we follow, in HPV positive, in early oropharyngeal T1, T2 lesions with node negative, primary modality of treatment preferred is surgery. And similarly, in the patients who are T1, T2, T0 with N1 with less than a 3 centimeter, preferred modality would be surgery. And for HPV negative, even for early lesions with T1, T2, N0, N1, preferred modality is surgery. So now what is the advantage with robotic surgery? First of all, it is minimally invasive. We go through the mouth and do the surgery. And apart from this, technical advantage is magnification is 12x, 3D view is there, which helps the surgeon decrease the learning curve, and improved anatomical details are there, and much more precise movements when a surgeon moves with hands. It's quite like doing surgery with your hands. And other advantages: decreased blood loss, early recovery, and early discharge. It avoids tracheostomies, and patient resumes early feeding. Definitely, surgeon is comforted while doing this surgery. And disadvantage is definitely their cost, but in due course of time, as Da Vinci's patent is expired, so we will experience that cost will certainly reduce for these patients. So the trend in management of oropharyngeal cancer in US is primary surgical. And coming to the retrospective systemic reviews for TORS versus radiotherapy, oncological, if you see that it's similar. So now coming to the only trial, randomized trial, which we have, where we compare radiation versus TORS. This is called a ORATOR trial. It's only a randomized trial for early oropharyngeal cancers, T1, T2, and nodes limited less than 4 centimeter. It had less number of patients, but equally distributed among the arms, and 90% of the patients were HPV positive. So coming to the oncological outcomes, when you see the overall survival and PFS were excellent in both the groups, and they didn't find any significant difference between the groups. But 12% of patient in the radiation arm required salvage surgery. So the main objective of the study was to find the swallowing of the patients, how they are doing it. So MDADI scoring system was used, and total MDAI score was better in patients who underwent radiation as compared to underwent surgery. But this difference was not found to be clinically meaningful. And there was one patient in radiation arm who had PEG at 1 year even. So other retrospective study also showed that the functional outcome with TORS is better. And apart from that, you can wisely choose the patients who are going to get adjuvant therapy, depending on the risk factors, on pathological risk factor after surgery. They will give radiation therapy or chemoradiation, and around 15 to 30% of patients may not require any adjuvant treatment for the management. There are other studies which are undergoing, but results in due course of time, in 2-3 years, we'll come to know. This is a European study in a similar lines of ORATOR trial. So coming to the real world scenario, which in India or in Indian subcontinent, HPV negative patients are much higher. So we don't have any randomized trial. One trial was started, but could not accrue. The patients was stopped. So does surgery have impact on overall survival? This was one of the a study which was published by Kamaran et al. From Department of Radiation Oncology from Boston Medical Center, where they reviewed 22,000 patients of stage 3 and stage 4 locally advanced oropharyngeal cancer from 2004 to 2013. And they found that patient who underwent surgery with adjuvant treatment versus CTRT had fared much better. Irrespective of HPV status, patient who underwent surgery in locally advanced patients, oropharyngeal cancer, the OS was much better. So now coming to one of our studies at AIIMS, which was published just last year in head and neck, and they did a match pair analysis of patient of HPV negative who underwent TOS, transoral surgery, or majority of them underwent robotic surgery versus radiation therapy. And they didn't find any difference in OS and DFS in stage 2, stage 3, but significant difference was found in patient who was stage 4. Stage 4 means T1, T2, but with larger nodal burden. So definitely we have to look into it that locally advanced cancer should be managed with trimodality. So TORS in salvage surgery, definitely it is found that for early oropharyngeal recurrences, TORS has found to be much beneficial in controlling locoregional recurrences as well as in minimizing the morbidity. So one of the studies which was presented in this FHNO, recut study from Dr. Vinit Pallari from his permission. He had done a study of including 16 international centers, of which 2 from India, and 278 patients were accrued. And in salvage setting, at 2 years, he found that local recurrence-free survival was 70%, and at 5 years, it was 62%. So local regional recurrence-free survival did not have impact whether the patient was HPV positive or negative. So local regional recurrence-free survival was quite high with TORS. So one of a patient who was a case of lesion, you can see here, is a small lesion, T1 lesion on the GT sulcus nearing the BOT. So what we did with the TORS, you can see this is the exercise system which we are using, and we have given a palatal cut, tonsillar cut. Then we will go to the lateral pharyngeal wall, and so base of tongue cut is there. So it gives a wonderful view with good control. So it helps in achieving minimally invasive body cancer. So this is the base of tongue cut. So this patient was a patient who didn't require adjuvant treatment, and he did well after that. So now one of a patient who was having a small recurrence after chemoradiation. So we have to choose that. So you can see a small lesion in the base of tongue, which was not picked up by CT or MR. It was picked up by patient having some foreign body sensation. And this small lesion are best suited for transoral robotic surgery. So this is a very inaccessible area otherwise. So, but with robotics, you have a good vision. So you can remove the vallecula here. Otherwise, it's very difficult area in open surgery to approach. So after resection, you can see the specimen is oriented, goes for frozen section analysis, margins are confirmed. Then patient can be discharged very early. That's the basic advantage of this surgery. So in the end, I would like to say that TORS with adjuvant treatment confers equivalent survival, local regional control, and a good functional outcome in HPV positive, and confers better oncological outcome in locally advanced oropharyngeal HPV negative patients. And for salvage, for early oropharyngeal cancer, TORS should be preferred over open approaches. Thank you.
Thank you. Hello.
So thank you so very much, sir, Dr. Badit, for this presentation. Now, we invite Dr. Shamit for his presentation. Over to you, Dr. Shamit, sir.
Great. Tarun, I hope my presentation is visible and I'm audible.
Absolutely right, sir. Absolutely.
Good afternoon, everyone, and a special hello to the organizers and thanks to them, and again to Mudit for setting the stage for this very.
Okay. Yeah. Hello, Shamit. I can see the robot picture in your first slide. Okay, come on.
Yeah. So that's the disclaimer that we have, right? The first disclaimer is that just like Mudit, I'm a robotic surgeon. We believe in certain aspects of robotic technology, and it's all a good-natured debate. A debate is such a refreshing break from the tenor of a medical conference, where we can afford to take pot shots at each other. But of course, not just being friends, but because also we want to communicate perspectives. I will talk about a little bit of the cautions that we have experienced, not only us, but institutions which have done thousands of cases now in their experience with robotic surgery. Mudit had his evolution slide, and this is an evolution of the adoption of robotic technology in robotics. And this is, of course, the caution article. You can see that in this paper, and again, I'm borrowing a little bit from uro-oncology, but the practice trends change, sometimes not to our best when we talk about adopting a robot within a community. So whenever there is a higher proportion of a robot in a community, hospitals are also more likely to acquire one. A light-hearted take, but still worth taking with a pinch of salt. With this understanding, we'll first talk about general perspectives about robot and why we think that there are certain features that make us consider it as a hype. But also we'll talk about things more specific to oropharyngeal cancer in general. A list of advantages that Mudit started off, and I'm also listing. One of the biggest advantages that was touted for surgical robotics, which was telerobotics, has really not met what we expected it would. The prospect, and this is again for the benefit of all of our non-surgical oncologists also, the initial prospect that was promised of delivering a robotic surgery to a person 1,000 miles away has not really been born with fruition. And the reason probably is ethical considerations and other things. But one of the biggest advantages that was touted of robotics has really not met its goal. Of course, when you talk about disadvantages, Mudit alluded to the cost. I'm giving you a little bit more of an Indian perspective. Right at the top, this is roughly what we're looking at. Actually, the cost effectiveness, even though all of us have tried very hard in our country to subsidize robotic surgery for our patients, and again, Mudit belongs to an institution that's done thousands of them across 2 or 3 specialties. We've done a few hundreds now. We really have found it a struggle to be able to extrapolate robotic technology to every individual case that would be justified to meeting them. Not only the cost, there are multiple studies that have been done on this. Not only the cost, but the setup initially allows for increased operative time. Just like any other surgery or any other advanced technique, you have a setup time, you have a learning curve. The instrument is bulky. Mudit mentioned the potential incoming of people other than Da Vinci for head and neck surgery, but currently, a lot of people think that the intuitive surgical system is just too bulky for head and neck surgery. In some cases, we realize the same problem, especially with the XI system. We use the SI, which is good for head and neck. That being said, even that sometimes becomes a little tricky in patients with trismus and in patients where you really have to go to the supraglottis. You don't get tactile and force feedback. I know the company is working on that. Hopefully we'll have that. And of course, training is a big thing. And when you talk about training, there have been a lot of systematic review protocols that have been reported. But again, talking about India and the problems inherent to our population, these protocols have not really been implemented. I remember my time as a fellow, I used to go back to Michigan every 2 years after returning from India to maintain my credentialing. But in our country, we need to still do a lot, which is, again, a component of the hype that is associated with that. Talking generally, this will be my last general slide about the hype that robotic surgery is associated with. The same papers that we talked about minimally invasive surgery and robotic surgery potentially helping us with the decreased blood loss, better recovery, and an increased and early discharge does not really apply to head and neck again. This is the most widely quoted systematic review, over 14,000 patients, the TAN meta-analysis. Of the 80 odd studies that were considered, only 3 were head and neck, which means that the benefit of early recovery, early discharge, decreased blood loss may not necessarily apply to head and neck. And when we looked at robotic versus minimally invasive surgery, there were no head and neck studies that were considered, which maybe makes you think with a pinch of salt again, whether or not it is ready for implementation across the board in head and neck cancer. Of course, FDA approval and the studies that have come subsequently indicate that yes, it is ready for extrapolation, but there are things that you have to take and you have to balance your own reasons. Of course, the big question in oropharyngeal cancer, we will only be talking oropharyngeal from now on, no more general considerations, as to whether the patient ends up in an RT planning console or whether he'll be benefited by the TORS surgeon's console. And the advantages of both have been listed over here. One meta-analysis that we as robotic surgeons quote very often is the McTaze meta-analysis about increased toxicity, grade 3 or higher with chemoradiation. The issue, of course, is that there are inherent problems with any meta-analysis, and we need to, again, take that with a pinch of salt as well. When we talk about survival, because the moot point is T1 and T2 oropharynx, remember that all of these studies are limited by what's listed at the bottom. All of them are single investigator, single institution, and retrospective for the most part. Prospective studies have really been the rarity in terms of our experience with TORS so far. When we talk about data on complications, again, we are talking about papers which are single institution, retrospective, and are biased largely by the philosophy of the individual investigator and have all the same limitations that you'd otherwise have. Another disclaimer, we'll only be talking about per primum here. And if there is a counterpoint and if time allows us, then maybe we can talk a little bit more about salvage that Mudit talked about at the end. But here you're seeing that a tumor, T1, T2 is being elegantly removed. And of course, it's a lateral oropharyngectomy that has minimal complications and sequelae. But that being said, this also needs to be considered very seriously as to whether there is some standardization of data that we have. Mudit briefly talked about PEG dependence. The figure on the right shows you the crude PEG utilization rate. And that is exactly what it is. It is crude as a performance indicator. There is no head-to-head comparison. Whenever you look at solving scales like the FOSS scale, there is no head-to-head comparison between how patients fared in robotic surgery compared to non-surgical organ preservation. And when we talk about PEG rate, there are multiple factors that are responsible for that. And the philosophy of using a transoral approach, more so transoral robotic surgery, may not really apply to this. It depends on subsite, it depends on the stage of the disease and other factors. Talking about function, the ORATOR trial is, of course, something that all of us are now familiar with. It had functional outcomes at 1 year and agreed that the MD Anderson dysphagia inventory is not a directed head and neck dysphagia screening tool. But that being said, we do have to consider that even if oncological outcomes are comparable, functional outcomes should also be considered. When we talk about phase 2 trials again, because of the lack of HPV positive disease in our country and HPV negative disease in the Western world, there's a large discrepancy of reporting outcomes, and therein patients from the Western world cannot be extrapolated into our setting and vice versa. To such an extent that RTOG 1221, as you can see over here, had to be terminated because it dealt with HPV negative disease. The ORATOR trial, of course, prompted our own reality check. We presented these findings from our institution at the FHNO meeting this year. We looked at 60 odd patients post-TORS who were surviving and functionally evaluable. And we realized that we weren't really able to decannulate G tube in this enteral dependence or tracheotomy tube dependence. For absence of adjuvant radiation therapy. And of course, that's prompted another search to look at other tools like video fluoroscopy, because this is based, but also we look forward to the data that will be upcoming. Since HPV plays such a big role in our future decision-making, it's important to know that surgical approach, which we are talking about currently, is not the only criterion. In HPV positive disease, there are multiple margins, requirement of adjuvant radiation therapy, what you're initially offering these patients. And therein comes the exuberance point that we talked about in the first slide when we talked about adoption of robotic technology, maybe too excessive. There are criteria for patient selection that all of us as surgeons should understand. Contraindications need to be as well understood. This is a nice paper, anatomical, radiological, and functional options to the surgery, and it's important that we know that. Couple of other critique points about widespread adoption of TORS for oropharyngeal cancer. There's no consensus on preferred transoral approach. To our non-surgical oncologists, we don't have data currently that TORS is better than the other transoral approaches. It's extremely important to know that, because when we're talking about a setting like our countries, where robotic technology is not widespread, only a few of us have the privilege of working with this advanced instrumentation. Other transoral approaches might also be viable for dissection of oropharyngeal cancer, which puts the entire philosophy of TORS in question to some extent. Margins, which are a hotly debated topic these days in oropharyngeal cancer, also have equal variability. So even though we get good oncological outcomes in T1, T2 disease, like Mudit pointed out, there's a variability across the literature, as you can see in margin positivity rates, the definition of a closed margin, and margin philosophy, what you're doing for your patients. Future literature, unfortunately, is unlikely to help in the immediate term. The earliest that we can expect the randomized phase 3 trial results is 2025. It still does not deal with HPV negative or margin positive or T4 subsets, which is the prime of doing TORS for oropharyngeal cancer in our country. If we don't get upcoming level 1 data on HPV negative disease, if we don't get it on T4 disease, it'll really make treating those 80 or 90% of oropharyngeal cancer patients difficult for us. And of course, it'll only help us extrapolate the available evidence to those 10 or 20% of patients who might or might not be able to benefit from robotic technology in the first place. So this is my encapsulation slide on present day role of TORS, and I hope all of you agree. And of course, we'll hopefully have a discussion to that also. We believe that TORS is a treatment option in HPV positive, to some extent negative, because Surinder has done a couple of studies which have hopefully will pave the way, but we need better literature as we go on. Early stage, well lateralized oropharyngeal squamous cell cancer in younger patients and potentially has decreased toxicity, but again, we don't have strong data for that. We know already that HPV positivity may have a lesser impact for Indian patients, largely because the large numbers are HPV negative. We've done a prevalence study in our institution, it's about 22% in our setting. De-escalation should not be routinely offered for HPV negative and even positive, I would say, except in a trial setting, because treatment protocols remain the same. However, currently, chemoradiation should be considered the standard in advanced stage disease till more data comes in, functional as well as oncological. Thank you for your attention.
Yeah, Shamit, nice presentation.
Yeah, thanks for that.
Right.
Thank you. And yours as well. Great. Thank you.
So, Dr. Vikas, you're there?
Wonderful. So, Dr. Mudit wants a rebuttal, or we'll give 30 seconds for either of them for rebuttal if they want.
So the thing what I would like to say to all the audience is robotic technology is a technology. One should not, if results are not there, it should not be blamed on the technology. It's the man behind. It's a master slave thing. So in this robotic technology, when you choose the right patient, that's why you have to be wise enough in choosing a patient. So if you choose an early patient who has got a good mouth opening, good exposure, I don't think so. Your margin assessment and everything should be there, and you should aim that your patient should not go for an adjuvant treatment. This is what I feel, that patient should get a one treatment modality. So other data which we in India, like HPV negative patient, which what we are getting, the data are, do we need to really intensify a treatment, not de-escalate the treatment? We do up-escalate the treatment so that we have some impact on OS. So we don't have much data on HPV negative, but the few data which has come from AIIMS recently from Dr. Alok Taka, I think he had some slides, but because of time, he could not discuss that that study which he has recently published in the panel. But we are hoping that we have to get together ourselves, that HPV negative data needs to be collected more rather than relying more on HPV positive. And as such, if you say margins, what he talked about margins, HPV positive or negative, because the Western people don't know about HPV negative, so they don't comment on the margins. But as such, if you see the Indian study or in HPV negative, margins are same. Recut study, which Dr. Vinit Palari has said, in that the margins when they say HPV positive negative, that was more than 1 mm that he was saying, and oncologically it was safe. So, but and this ORATOR trial, they were less than 2 mm. So definitely it is something like you have learned over in lasers when you do for glottic cancers, and things have come up. So same is in oropharyngeal cancers as well for the margins.
You know, because 30 seconds, asking a surgeon to speak for 30 seconds is difficult, right? But I'll try to be as concise and brief as Mudit was. So, you know, there are a couple of things. I did not cover salvage because we realized that a large proportion of this audience would also be non-surgical. But I have a couple of points on that. In advanced disease, in T4 disease, Indian data, including Dr. Thakkar's study on salvage, does not support the use of TORS for T4 disease. Now, that is a problem because in our Indian setting, 60% are T4 and 80% are overall stage 4 disease. So like Mudit said, I agree with that. We need more data on advanced stage disease. When we talk about salvage, based on personal discussions with the faculty from the same institution, they have very sobering data on salvage. And we are excited about that. I share Mudit's philosophy on the fact that if you have a T1 recurrence and the patient has all the other anatomically favorable factors, I would consider TORS. That being said, data currently really cautions us otherwise. If you look at RECUT study, which he also alluded to, HPV positive was the vast majority. And again, unfortunately, we in our country need more data on HPV negative disease before we can move forward with that. As regards margins, my last take would be that current consensus, because we presented a lot on this of late. When you talk about HPV positive disease, there is virtually nothing called a close margin. If you get a clear margin, it's considered a clear margin, and the same prognostic implications that apply to HPV negative SCC do not apply to that. When we're talking about HPV negative disease, however, then the same dogma of 5 millimeter we have to follow till the time that we get better data on that. I think Mudit also mentioned something like a preferred modality when he was talking about the guidelines. I think there was no preferred, to my recollection, in NCCN 2022, there is no preferred indicator. It's either definitive RT or resection. And like he said, certain factors have to be considered, including mouth opening, patient's functional reserve, anticipated compliance to protracted therapy, as to whether you can save that third modality of treatment. So multiple factors. But bottom line is, for our country especially, we need more data on advanced stage disease and HPV negative tumors.
So the thing which I will say about locally advanced is locally advanced doesn't mean T3, T4. It is only T1, T2, but with larger nodal disease. So it's always that you are not going to resect more than 50% of the base of tongue. That will have a poor outcome in these patients. Or you have to use free flaps and all these things. But locally advanced means with T1, T2 lesion with larger nodal burden. That's what we think of.
Sure, agree. And could I address Dr. Sapna Nangia's question? Madam, I think unexpected mortality has not been reported extensively in TORS literature so far. It's largely anecdotal and for the most part has been attributed to hemorrhage as opposed to otherwise. There are multiple things that we do as TORS surgeons to address that hemorrhage, including the ligation, because most of these patients will also need a neck dissection. Because we're talking about squamous histology, most of them will, because oropharynx has a high incidence of nodal metastasis. Regarding your other point.
Sorry.
Yeah. So
I do remember a mention of 2 patients having died unexpectedly, including one in the orator trial.
Excuse me. Orator trial, 1 patient died. Because of that, the trial was held for 1 month and that was reopened again. And because of that, they became more apprehensive and more of tracheostomy were done. And they made it.
So then coupling tracheostomies were required. And that is, when we are trying to do a treatment which is supposedly, less toxic or designed to restrict the toxicity of the other modality, I believe that bears some.
I have a point to this unexpected mortality before we move on to your tracheostomy question. When we talk about unexpected mortality, there is unexpected grade higher than grade 3 toxicity with radiation, with or without chemotherapy also. So these outliers should probably not form the basis of our academic decision making. That being said, your point is absolutely well taken. If we are going to consider a modality which has purportedly better functional outcomes, we should consider everything that we can to avoid the unanticipated morbidity mortality, just like you do for us in radiation oncology, just like you've been leading proton, largely the same parameters. Regarding the other point that you made, again, very important question. Head and neck surgeons' axiom is, if you are thinking about a tracheotomy, you should do a tracheotomy. It's a very crude way of looking at it, but there are now criteria that we have outlined to decide which patient with TORS should receive a tracheotomy, and that applies to all transoral approaches, not just TORS. Well lateralized oropharyngeal tumors who are only going to get a lateral oropharyngectomy, and herein is T1, T2, would probably be the only ones who might not get a tracheotomy. And I say might not because even despite that, some of them will. Most of the others, including base of tongue and supraglottis, I would say all of them are electively tracheotomized at our institution. I think I speak on behalf of Mudit as well. However, in the absence of objective criteria, the decision-making for tracheotomy, not just in TORS, but all head and neck cancer remains largely subjective. Loss of suprahyoid muscle support, anticipated oropharyngeal edema, and all those other criteria will typically form the indications. But very insightful questions. Thank you.
Thank you, Dr. Mudit, and thank you, Dr. Sapna, and thank you, Dr. Shamit, for an very interactive debate. In view of shortage of time, we have to move forward, and we feel very enlightened as this.
It was a privilege.
As this modality will definitely take over in next few years as the primary modality in most of our guidelines. So moving on, I feel honored and privileged to invite the next speaker, Dr. Kumar Prabhash, who is the head Professor Medical Oncology at the prestigious Tata Memorial Hospital, Bombay, for the next panel discussion. Dr. Kumar doesn't need any introduction. You can Google him up and you will find probably the Google might be exhausted with the amount of the publications he has, and a humble human being and always a great teacher to look forward to. Over to Dr. Kumar Prabhash, sir, for the panel discussion, sir.
So we also, let me have a pleasure to, by the time you set the slides, sir, we have a pleasure to introduce the esteemed panelist. It's a pleasure to welcome Dr. Naresh Somani, sir, Director and Head Medical Oncology at the SCG and Somani Hospital, Jaipur. We have Dr. Ashish Kaushal, Director and Head Department of Medical Oncology from SCG Cancer Center, Ahmedabad. We request Dr. Vikas sir to stay back. We have Dr. Vijay Patil sir, Professor Medical Oncology from Tata Memorial. And of course, we have Dr. Anuba, Head of the Department Medical Oncology and Hematology from Jalandhar. Sir, all your panelists are there except for Dr. Sameer Khatti sir. He is not able to make it. Over to you, sir. So you have 30 minutes to dwell on your presentation, please.
Thank you. Thank you for kind introduction, and thank you, Vikas, for this opportunity. And that's why the friends are for, to say good things about each other. And so we'll move on to the panel discussion. We have a good panel. What I'll request is, Dr. Mudit and Samit to stay back for at least for initial 5 minutes. And this is I think the first question Vikas wanted me to take it. Which are the patients which are there for local treatment when they come back? And maybe we can, if Vikas agrees, then we can put this question to Dr. Samit. Samit, which are those patients when they recur back? If you can give a hint to our other modality people that they should think about a local treatment in this setting in head and neck cancer.
Hello, sir. First of all, did you mean me? I'm a happy addition to your panel anytime.
Absolutely. That's why I initially requested Mudit and Samit to stay back for a few minutes.
Sure. I'm sorry, I got logged out for a minute. I think it was some network issues at the hospital currently. When you talk about local treatment, do you mean local treatment for all recurrent metastatic, recurrent head and neck cancers, correct?
Yes, recurrent and metastatic head and neck cancer.
I think this question can be divided into two parts, sir. The first one is the recurrent cancer, and the next one is the cancer of the head and neck, which is recurrent as well as metastatic. So the first thing I would aim at is, if the patient is non-metastatic but recurrent, local control and progression-free survival remains my primary goal. I would not consider there's enough data that debulking, local debulking in oral in head and neck cancer, recurrent or per primum, has absolutely no survival benefit. I would aim at those patients who have the possibility of a negative margin resection, first of all, the ability to be able to go in regardless of approach and be able to make sure that we get a microscopically negative resection, therein increasing the possibility of either disease-free or progression-free. And that depends on whether we're talking about recurrent alone or recurrent metastatic. In the metastatic subset, of course, the indications for metastatectomy in head and neck cancer or removal of recurrent disease in metastatic head and neck cancer are not very well defined. I would stay away for the most part for those patients and aim only at symptom control, wherein the recurrent and metastatic patient becomes a candidate for no local treatment, but the recurrent non-metastatic becomes a candidate for local treatment. And when you say local treatment, I can only speak on authority on surgery. So the first subset will typically be considered for surgical resection. I would consider doing a very astute systemic survey. A PET in the majority of these patients, they have to be negative. Presence of nodal burden only decreases the prognosis, but does not necessarily rule them out from local treatment. I would also keep in mind their functional perspectives, a detailed discussion that in most studies, even with treatment, these recurrent patients have a 12 to 18 month median survival. All those considerations I would take into consideration.
Can I take the same question to Dr. Mudit? Mudit, in your practice, similar thought process, or do you want to put some situations that think about T4 N2 tumor, you did surgery, coming back in 3 months, again it is T4, resectable margin, because you could do T4 earlier, most likely you could do T4 now. Or does it matter this previous T, now T, extent of resection? Mudit is around, or have we lost him? If we have lost him, then I'll take this question back to Shamit. Shamit, does these factors count for you? Disease coming back in 3 months, disease coming back in 15 months. And does this borderline definition, there's no formal borderline definition in head and neck cancer. We know that we have been trying to put in, and those we put it upfront. But in recurrent setting also, you get into those situations where you say it is iffy about it.
Yeah, so if it were coming back within a disease-free survival period of, let's say, less than a year, we already know that the disease is very aggressive biological behavior. Even if the patient is non-metastatic and has recurred at the same site, I would be very circumspect about the patient and giving the patient a positive outcome. In that sense, the patient is resectable but may not be curable. I would have a very detailed discussion with that patient about the potential for further surgery only being for, let's say, local palliation or symptom control, but not really offering a serviceable survival. Having said that, let's say we get a second primary within the head and neck, which is also a common enough scenario. In that case, even though I would say that, again, it would be a very subjective decision making, but I would probably be compelled to go a little bit more into it. And that way my counseling would be different. Then I would counsel the patient that, the entire mucosa, that condemned mucosa field cancerization philosophy. So the entire mucosa has a propensity of developing primaries, but in this case, I might offer definitive treatment to that patient as long as the initial primary site is sanitized. In your first subset, I would be very concerned indeed, however, and I would have a very long discussion with them, talking to them about pros and cons of treatment.
So I think it's very nicely put by Dr. Samit that, when you have a given chemoradiation and the residual disease is there, you are aggressive. When it is a recurrent disease, you need to look into patient characteristics, the tumor characteristics, and also it is a second tumor or the same tumor coming back, and that will help you decide that how much you want to operate. But earlier the disease comes back, you will be more conservative when you want to operate. Coming to the next local treatment is the radiotherapy, and here I'll try to rope in Dr. Sapna Nangia, madam. Madam, re-irradiation. All patients, post-surgery, definitive, and when you'll say no, not a good idea.
So thank you, Dr. Prakash, for including me in this. I would say that, firstly, I do believe that this treatment of recurrent head and neck cancers is extremely treacherous. And as mentioned earlier in the discussion, disease-free interval is a very important consideration. So as far as disease-free interval is concerned, though it is cutoff is considered as 1 year or even 6 months. However, if we look at the MIRI criteria, then the cutoff in terms of time seems to be 2 years. So 3 definitions: 2 years after surgery or less than 2 years without surgery, and so on. So I do believe that there are certain situations where we can offer radiation, but very, very judicious selection of patients, and also a lot of counseling, because if a patient has been previously irradiated, if a patient has never been previously irradiated, then of course their outcomes are better. But if a previously irradiated patient is being treated again with radiation, then perforce our fields are limited, and because of that, out of field failures remain an issue. Bad biology is of course an issue, and toxicity is an issue. So yes, very judicious selection is what is needed.
So if I summarize this way, if you have residual disease after radiation or chemoradiation, further upping up is of not benefit, and we should avoid it.
No benefit.
If we have salvage surgery, then RT, if you can put it, it is very good idea to do it. It adds benefit to the patient, adds some systemic therapy also with this. But if it is definitive treatment, then it becomes a challenge. And those situations when the disease come back, where it came back, what was the earlier stage, subsequent stage, what is the stage now, and that decides how aggressive we are going to be. Am I summing it up well, ma'am?
Very right, Dr. Prabhash. Of course, you wouldn't do any less. But on the other hand, I also want to mention that one of the things that has been found to be important is the fact that if a patient has, tube requirement, basically, which means loss of functionality, so a tracheostomy or a tube feeding, there too the prognosis is poor. That is also another factor that should help us or make up our minds about the prognosis.
Thank you, madam. Thank you for that point. So coming to the panelist here, and I'd extended it because that was the kind of question Vikas had put in. So we will take a supplement from the panel. Dr. Vijay, chemoradiation or radiation, post-op or recurrent tumor when RT is possible to be given? And if chemo radiation, which chemotherapy?
Sir, what I would say here is that at least a disease-free interval of 1.5 to 2 years, and would discuss this in the multidisciplinary clinic, how if it is feasible for surgery or if it's feasible for radiation. So if it's feasible for surgery, 1.5 years DFI, then I think it would be to go for surgery and then boost it with a post-operative chemo radiation, not only radiation, because the only evidence which is there for post-operative adjuvant after a salvage surgery is for chemo radiation, published by in JCO in 2008 by Dr. Francisco Janek. If the patient is not a candidate for surgery, or if it refuses surgery, then definitely chemo radiation in that situation. Now, which concurrent chemotherapy would be using, it completely depends upon what the patient has received previously. So if the patient has received previously no concurrent or no adjuvant chemotherapy, I would still go with cisplatin in that situation. If the patient has received adequate doses of cisplatin previously, let's say around 200 or 300 milligram per meter square, then giving subsequent cisplatin is very difficult. In that situation, then I go for non-cisplatin regimens, and I tend to use the regimen of either 5-FU hydroxyurea, which was given by Dr. Janet, or carboplatin 5-FU, which is in accordance with the GORTEX study, or according to the RTOG 2034, a combination of docetaxel cetuximab. So this would be my preference, depending upon how the patient is built and what is his tolerance.
Okay, so this is for if you want to give local treatment, and that time if you want to add systemic therapy to this treatment.
I have a question for you, sir. Yeah.
Go ahead.
So if you look at if the patient has a good biology, you operate the patient, you give concurrent chemo radiation after that. Still, the Janet data suggested that the 3-year survival of this patient is 20%. Let's say that you have a patient who has a PDL1 score of 90% and it comes to you, or let's say you have a microsatellite instability, it comes to you.
I got
it. And the patient is resectable, patient is and you have data with pembrolizumab that the 3-year survival will be probably more than that or similar to that. How would you choose?
I'll come to that. That question is there later. Is that okay?
It's okay with me.
Is that okay? Good. So next question back to you only, Vijay. What do patient wants?
So
your paper only.
Yeah. So this was an so what I had seen. I'll give you a background story here why we did this data. So at medical oncologists, we most times our surgical and radiation colleagues criticize us, okay, 2 months benefit, 3 months benefits. Why are you giving chemotherapy? Why the patient keeps going? So we decided that there was no data where someone has counseled the patient about what the prognosis is and asked them. They are the consumers. Ask them what they want. And so this idea was So we had made first a validated question and to capture this, and then we did the study in data, and this was done in under your supervision only. And what we see here is that in spite of knowing that the prognosis is bad, you could see here that nearly 41% patients are ready to take for that benefit which chemotherapy offers chemotherapy, and nearly 76% of the patients, their objective of taking therapy is for prolongation of life. There are a subset of around 1/4 of patients who are not very
so I think so
prolongation of life, but for symptom relief.
Yes, I think Vijay, what you want to convey that patients has a very expectation from their clinician, isn't it? Yeah.
Yeah, that's correct.
Yeah. Dr. Naresh, is it similar in your experience?
Yeah. So patients, as long as they, when we offer them the low-cost treatment, they always grab it or they take it. The moment we start talking about the immunotherapy and all, this question of the 2-3 months of the overall survival or PFS always comes in the mind. So it depends on that, what is the actual cost of the treatment that actually forces them to decide the treatment.
Okay. And when you have a longer discussion, do you have varied opinion from them?
Yes, always.
Always. Yeah. So this is true that I know, and this we learned with this work. I know. So go to the next question, and maybe we'll focus for some time for chemotherapy, and maybe we'll go to Dr. Anubha. Dr. Anubha, we take it here that majority time today also we keep using chemotherapy. We do use targeted and immuno, but in the meantime, we keep using this. What is the commonest chemotherapy used, and do you want to compare the single drug, two drug, and which situation, and how do you choose them?
Thank you, sir. So when I look at a patient who has been sent for chemotherapy in the metastatic setting, first and foremost, I mean, we have to assess the patient, the comorbidities. I ideally would prefer, and I'm talking majority of my patients, sir, are not going to get immuno and targeted therapy because it is beyond the reach of most of the patients. So even having the discussion about getting a PD-L1 is most of the times out of the picture, and it's regular chemotherapy. And my preference, if the PS is good and the renal function, etc., is adequate, and the performance status is good, I would prefer a doublet over a singlet therapy. Because most of these patients they need symptom control, and so in that situation, my preference is for a doublet chemotherapy. Having said that, the majority of the data is for CIS5FU. I can confess that doing that 96 hours infusion, let us be frank, most of our patients are not going to get admitted for that, or do the port. I mean, everything. And again, a point I would like to bring up is most of the head and neck patients are your socially or socioeconomic backward patients. This is, getting a very, somebody who cost doesn't matter really, is that there is a very small subset of our patients. So I confess that most of my patients end up getting docetaxel, cisplatin, or carboplatin, paclitaxel. And I guess, and I would welcome other people's opinion. I know we have your data for the metronomic chemotherapy.
We'll come to that.
Okay. Yeah.
Thank you so much. And this is what is important to have a discussion and knowing from what we do it. And that's what I always think the panel is all about. And thank you so much for that comment on that. Coming to also, this was chemotherapy. We'll revisit it when we combine the other data to targeted therapy. And maybe we can ask Dr. Ashish Kaushal. Targeted therapy, we know there is one of them which has been positive till now. How do you use in your clinic when you use it? How commonly you use it? And when you use it, how you use it? There was a comment by Anubha that 5FU platinum 96 hours, hardly ever she uses it. Your view, Dr. Ashish?
Yeah.
And targeted therapy, how do you administer? Same one, extreme, or you modify? How you modify?
Yeah, Kumar. Thanks for the question. I think I would agree with Dr. Anubha. In a recurrent head and neck cancer patients, I think it's very difficult to give the infusion treatment, especially for 5-week infusion for 96 hours. So I think as of now, I divide the patient into the 3 or 4 category. If the patient is affordability, because I am practicing in a private setup where most of the patient can afford a combination chemotherapy, and around 20 to 30% patient can afford some kind of the monoclonal antibody and immunotherapy also. So the preference based on the patient's general condition, performance status, and affordability, of course. But I believe the combination of the chemotherapy with some sort of targeted or immunotherapy would be my first preference in our practice. But I don't practice a 5-FU infusion in my first-time treatment in a recurrent metastatic patient. As you mentioned, the extreme, I think I have shifted my practice from extreme to the TP extreme, and that would be my first preference. And I keep usually the immunotherapy agents at the subsequent line based on my own experience with this combination, because this is very easy to administer. It's a one-day regimen and just a 4-cycle, and then keeping the immunotherapy as the second option. A lot of oncologists, they're using immunotherapy as a first line, but I think in Indian scenario, giving the ideal immunotherapy with 5-FU infusion is really challenging for this particular patient. So my practice would be more TP exchange the first line and keeping the immunotherapy in the second line.
Thank you, Dr. Ashish. Then we go to the next question for discussion. Immunotherapy. Again, how commonly we'll ask this question to Dr. Vikas, and we'll revisit it again after some time. Vikas, how commonly you use it, and then what is the challenge in the clinic when you decide between cetuximab and immunotherapy in the first line treatment, in these patients, and then how do you deliver it?
So I agree with all my panelists that immunotherapy and targeted therapy is something which is a choice for a few patients. Most of the patients do go on single or double chemotherapies based on their performance status and comorbidities and other and the disease burden. Those who are affordable, we usually give them the option of getting a PD-L1 testing done so that we know their CPS score, and based on their CPS score, if the CPS score is encouraging, it's more than 20, I usually go for a single agent pembrolizumab. Between 1 to 20, I usually prefer the combination of chemos plus IOs. For less than 1, we usually prefer the cetuximab based chemotherapy regimens if finances are not an issue for these patients, because we know that for those who have a response, they are going to respond with the immuno, and giving the best agent upfront is probably the best way to go ahead.
So, we learned that many times we do. Go ahead, Dr. Naresh.
Sorry. So what I understood is that contrast to many other malignancies, the PD-L1 expression in head and neck cancer is not so dynamic. It remains more and less similar since beginning. So does it really mean that what Dr. Ashish Kaushal commented that he want to use it in the second line? Does it really make any difference if we see the PFS 1 and 2 or OS 1 and 2, whether we use the immunotherapy in the first line combination or a single agent in the CPS more than 20, or whether we use it in the second line? Does it really make any impact?
Ashish, do you want to comment on it?
Yeah, definitely. I think I would be more comfortable in keeping this a second line, because the ideal recommendation, as Dr. Anuba is mentioning, the 5-FU cisplatin, I think that is really challenging in our patients, and keeping immunotherapy would be more easy. And I think the other advantage is there is a lot of PAP in the second line. But if we, and the only patient where I do consider immunotherapy first line, as the Vikas is mentioning, the high PD-L1 patient. At the same time, if the patient is not a candidate for chemotherapy, if the patient is elderly, the patient performance is not good, I think these are the scenario where probably the immunotherapy scores over the chemotherapy. But I think sequential treatment, keeping the initially chemotherapy and the immunotherapy in the subsequent line, that would be the way I usually practice, considering this category of the patient, they cannot tolerate very aggressive combination treatment.
Okay. So,
Dr. Kumar, sir, sorry to interrupt. Another 5 minutes, last 5 minutes to conclude.
Okay, we'll complete in 5 minutes. So this was Anuba, which she wanted to discuss, and yes, we'd like to have opinion. Dr. Anuba, when do you use it, and how commonly you use it?
Sir, I do use methotrexate chemotherapy, but I will admit that I use it for my patients whom I don't think is going to be able to get the regular doublet chemotherapy. So, and in those cases, I do the triplet, the regimen that you talked about, methotrexate, celecoxib, and the erlotinib. And the other advantage that I have found is So generally I have found myself, and this might be my bias, but I generally tend to give it to my older patient who is not able to come very frequently, who I don't want to have any side effects. And also the patient who's not very symptomatic, sir, I would prefer to use it in that patient. So those are the things I look at when I'm looking at metronomic chemotherapy. My experience is not obviously we haven't given it to that many patients, a few patients, but they generally tend to have stable disease is what I found, more than a response. And 6 months, 9 months, we are able to get away with it.
Dr. Somani, metronomic chemotherapy, do you use it? And if you use it, when do you use it?
I do use, and I use it preferably, but I usually give afatinib 30 milligram, maybe 5 or 6 days in a week, and along with the oral methotrexate, like twice a week, along with the etoricoxib. This is what I practice for the metronomic.
Okay. Dr. Ashish, do you use it? And if you use it?
So my largely practice of metronomic chemotherapy in the second and third line. So those patients who is treated with platinum and taxane, then probably that's the largest category. But even the patient who receives cetuximab first line, immunotherapy second line, I'm keeping this in the third line if the patient has progression after that. And I usually use the triple drug, and my preference would be a methotrexate, celecoxib, and gefitinib that I usually do.
Okay. Vikas?
So quite a few, I would say a lot of my patients from second and third line go to metronomic therapy because we have seen those responses. I would like to disagree with Dr. Anubha for just this thing that they have a stable diseases. They do have a very good responses because those fungating masses, those bad growths usually disappears sometimes with exceptional responses we do have where we see every one of us has these experiences of these patients. But yes, the durability of metronomic is an important factor. 3 to 6 months, they have a progression. Those who are not affordable for the standard therapies, metronomic is the way to go ahead. And I also use the trio combination of gefitinib, celecoxib, methotrexate, and when they progress, I tend to switch from gefitinib to afatinib, being the afatinib is available, and those responses tend to reappear. So that's my personal take for it, that we use the cheapest of those combinations and then probably add afatinib as a reserve drug when they fail with the combinations.
Thank you, Vikas. Dr. Vijay, if you can summarize the metronomic use, combination, and triple metronomic, and use and the benefit to the patient.
My choices actually depend upon, and I agree with most of the panelists, the finances and so I actually discuss with the patient how symptomatic he is and what is the bulk of the disease. Because if you are going to use double metronomic, the response rates are going to be less than 10%. But if you're going to use triple metronomic, even in a platinum refractory setting, triple metronomic tends to give you 50% roughly response rates. And we have an ongoing trial, and you are aware of that. In the first line setting, we are using it, and it tends to give around 60% response rate. So if you are using triple metronomic, response is not actually an issue. So a patient who wants so double metronomic, there is good amount of data now that's in with head-to-head with cisplatin. It gives you an overall survival advantage. When I look at head and neck cancer with respect to whether you use single agent chemotherapy, double agent, or triple agent, addition of paclitaxel to carboplatin or addition of taxane platinum to 5-FU have actually not led to an improvement in overall survival. So, and metronomic did lead to an improvement in overall survival, and that came with quality of life improvement. So I think somewhere down the line in the natural history of the course, metronomic needs to be there for the patients. And it is up to the individual medical oncologist to decide what would be the preferred first option, looking at the social status and the economic status and what are the expectations of the patients. But dual metronomic chemotherapy will give you responses less than 10%. It does tend to still give a good progression-free survival and overall survival. Triple metronomic tends to be better, good response rate, better progression-free survival, and overall survival data also with respect to historical comparison looks to be good enough. In fact, if you can give me 1 minute more, I would add that we have a new combination, and which one of our students, Dr. Gunjesh, also is a part of that, is that we have combined paclitaxel carboplatin 3 weekly interspersed with triple metronomic chemotherapy. We at present use it as a neoadjuvant regimen, and you remember when I showed you the first results, we were very excited because it tends to give responses in the range of 70 to 80%. And we have a TMC center in Muzaffarpur where giving DCF and all was not that possible, or even in where this regimen was used extensively in around 100 plus patients, and the results which have come from this regimen seems to be a very good with respect to good response rates, and with respect to tolerability also it seems to be good.
Can I put a question in front of Dr. Kumar and Vijay Patil? When the patient's affordability is not a problem and PD-L1 expression is something like 1, and patient is fit in all sense, how you sequence the chemotherapy with cetuximab versus immunotherapy with chemotherapy? What will be the preferred? What is your insight?
So I will.
CPS less than 1%, na?
Yeah,
PD-L1 is the 1%.
1%. Which at PD-L 1%, you can negative.
Sir,
go ahead.
The issue here is, though the graphs of PD-L1 1% of pembrolizumab looks better than the graph of cetuximab, the problem comes is, if you see the number of patients who progressed on pembrolizumab alone were very high. And even so, if the patient is symptomatic and the bulk is high, either we would use a pembrolizumab plus chemotherapy or cetuximab plus chemotherapy. But alone for me in this situation is out when this PD-L1 is 1. In fact, even if the CPS score is more than 20%, if patient is symptomatic and is a bulky disease, because the progressive disease were quite a bit high in the pembrolizumab alone arm, and the response rates were actually low. So for me, if the patient is symptomatic, it's bulky, it always has to be either an immuno plus chemotherapy combination or a chemo plus targeted therapy combination. That's the way I use it.
So, Dr. Patil, my question is a little bit different. That does it make the difference in the outcome of the one treatment if we change the sequence? Like something we used to talk in the colorectal malignancy, that you use the cetuximab first, then the response to the bevacizumab will be little higher.
I'll answer that. So when you look at the curve of pembro plus chemo versus cetuximab plus chemotherapy for even for more than 1%, at least in Keynote 048 study, the overall was on the higher side. So my preference, personal preference, will be in that situation pembro plus chemo if the patient can afford. Sir, you are muted, sir.
What Naresh was trying to say, that if you give cetuximab first, then followed by pembro, or pembro first followed by cetuximab, am I right, Naresh?
Yes.
Does it make a difference?
Yeah.
Sir, I would, my always is that you give the best treatment first. Most of our patients out of 100, 50% only reach up to the second. And so that's my preference will be here to go for pembrolizumab plus chemotherapy.
Kumar, there is one important catch here. Giving the immunotherapy first line and giving the cetuximab alone or with cisplatin in the subsequent line, because it's not approved with the combination with TP extreme. So I think the right sequence is giving the chemotherapy cetuximab followed by immunotherapy, because if you reverse that scenario, immunotherapy, that is not that much effective.
Always, Ashish.
Sir, but
only for
CPS
1% or always?
Sir, and isn't there data from the Keynote 040 that your responses, if you've given cetuximab first, is lower for I think it's with Nivo, that if you've given cetuximab, whereas if you're giving it fresh, there's a difference, and there is a lower response if you've given cetuximab first.
I agree with you, and then when you use taxane, and that decides, but that's a whole lot of subgroup analysis. We are not certain. So let me put this question to Ashish, which Vijay wanted to put me in box asking that question, so better I put someone else.
Last 2 minutes, please. Sir,
last 2 minutes only. This is the last question. So Ashish, this is not updated data. I am presenting a bit older. I didn't know that Vijay wanted the updated one. So now 3-year data is there. 1/3 of the patient will survive with chemotherapy plus immunotherapy. The first question is, now also cetuximab plus chemotherapy? Because in chemotherapy at 3 years, if you take the extreme trial, and then the data was less than half, and that time we didn't have a salvage immunotherapy. I'm not saying what is my view, I want your view.
Yeah,
and
I
second
think,
one, do you think this can start competing in due course with re-irradiation and surgery, or at least complement them? Ashish, go ahead.
Yeah, so Kumar, first of all, I don't practice extreme because I feel difficult giving a 5-FU infusion in recurrent head and neck cancer patient. So I think I have at least 2 options, either using the pembrolizumab with cisplatin or carboplatin with Taxane, because even with the pembrolizumab data, I think 5-FU is really challenging. So I feel comfortable using a TP extreme followed by maintenance cetuximab on progression immunotherapy. That is the way. And only the subset where the patient is not a candidate of chemotherapy, elderly, or PD-L1 very high and low volume disease, I think single agent immunotherapy, that would be my take on this category of the patient. So that is the way I usually practice, because 5-FU infusion is really challenging, I think. And there are also look for the, you are rightly mentioned, like if you look for the subgroup analysis, even for this Keynote-05 study, I think the Indian patients are, and is very, I think not Indian patients are not there. So Asian patients are very less, and the HR is not that positive. And if you compare with the chemotherapy plus immunotherapy arm, especially the PD-L1 is less than 20%. Actually,
Got it, Ashish. So Ashish says that 1/3 patient surviving beyond 3 years doesn't excite him. So Naresh.
I think that is, if you look for the subsequent line also, you can get the patient. There are a lot of patients who can still doing it. So I have a patient of giving a single agent immunotherapy in the second line nivolumab. And I think the own data is the patient who's reaching for 2 years is around 15%. So if you have those patients maintain their response, even the second line.
Got your point, Ashish. Naresh, Ashish says that give second line, and maybe second line make salvage enough that one can have 3 year survival beyond 30% with them in head and neck cancer if you use immunotherapy in second line.
So that was exactly the question in my mind also. But after this discussion, I have also changed, and I would like to go with Vijay Patil that give the best in the first line to achieve the best overall survival possible if there is no much difference.
So not only he put me in box, he is putting you also in box. Anubha, what do you think?
but we don't know which is because there is no direct comparison. We don't know which is the best treatment, because this is a different studies.
That's what panel is about. I totally agree with you. I am not saying that everyone needs to. Today we don't have a comparison. I'm just saying because there is a bit of exciting data, so that's the reason I think so.
But if you see second line data of
discussion,
data with Dr. Cohen and Dr. Felicis, the PFS with nivolumab pembrolizumab was only 2 months. So even if you give cetuximab, the PFS is around 7 to 8 months median. So you're bound to change after 8 months. The PFS with those regimen was around 2 months, and the number of patients which went beyond 2 years. Let's say that even you cross 1 year with the extreme leg regimen, number of patients who went beyond 2 years was in double digits, near 10%. So, and we know that in general practice, out of 100, at least in our trials, only 60 to 50% patients take the second line. So that's the reason my philosophy is, Baba, पहले बैट्समैन को पहला बैटिंग कराओ, ज्यादा से ज्यादा ओवर वो खेलेगा तो ज्यादा जीतने का चांस है.
So he says Virat Kohli should be always the opener. He never opens. Yes. Anubha.
So I think I would also, if the patient is affording and I would prefer to use the immuno first line. Not in all, I wouldn't give it to my less than 1%, and even the 1 to 20.
Less than 1% will be. Yeah. 60%. Then let me put it to Ashish. CPS 70%. Does it change your mind?
If the patient is high, as Vijay is mentioning, tumor burden, symptomatic combination, elderly, low volume disease, single agent.
Great. So I think so we had a good discussion. There was 2 more questions, but I don't think so that we should move to that. I think so we'll extend the timing. Vijay, with your question, you changed few minds. So thank you so much. Anyone has any last comment on this? I do agree. I think so what Vijay wanted to convey, this data, if it gets established, and maybe 4 year, 5 year down the line, if we have 1/3 people surviving, I think so what he brought was bringing about that, will it start complementing
we know that surgery or RT, there are short duration treatment. Patient lives without disease, which usually doesn't happen with the treatment we gave. But that was not the case till now. That question never came up because the median survival used to be around 10 months odd with cetuximab. So that the question is to never come over. But now once you have the 3-year, 4-year, 5-year survival, if it starts coming at around 30%, people will start discussing, is it something which we need to think about as alternative, which should be offered to the patient? Can be it a complementary, can be it a way of choosing patient, can be it a way of choosing patient. So I think that discussion will come up in case we get this data, which I know we have a 3-year follow-up now. That is almost all patients having 3-year follow-up. I know, but the curve has gone beyond 5 years. But I think so that curve maybe will wait for some time to have the definitive finding. Any last comment by any panelist?
I think, Kumar, there's one thing which is coming, the new adjuvant use. So once there is a new adjuvant data is going to be, I think all these things are going to be modified. So I think
I'm telling you, yeah. I totally agree with you that this discussion will be all null and void.
I agree with Ashish's comment on that. The way data of neoadjuvant immunotherapy is coming,
yes.
There is very high likelihood that in future that is going to be the standard of care, and then we would be actually looking for PD-L1 resistant inhibitors or resistant reversal phenomena. How we can, the discussions will be about that.
Only problem is that CT-RT is sobering data. That concerns you. That was
sir, I think Ashish is talking about neoadjuvant immunotherapy before surgery, sir.
Only comment is that suppose when the platinum is not the choice left for the patient, I sometimes try to give the taxanes as the 6 cycles along with the immunotherapy and then try to continue the immuno-oncology drug. I don't know how much I am correct or not.
So I'll just so what Ashish and everyone said that giving cisplatin 5FU based is really difficult. So we do give Paclitaxel plus plus pembrolizumab, and we have just now finished our first experience, and we have drafted it, and we are going to present it in ASCO also and send it for publication also. Along with that, there is in cervical cancer we have good data about Paclitaxel and pembrolizumab in 450 odd patient study. So I think safety is established with that regimen of Paclitaxel pembro if you want to use that.
Paclitaxel pembro is the highest data in the lung cancer. I think that we are all practicing.
So thank you all the panelists for nice discussion, and thank you Vikas for opportunity, and apology in case we exceeded few minutes.
Thanks everyone. See you. Bye.
Thank you, Dr. Kumar sir, Dr. Ashish sir, Dr. Naresh sir, Dr. Anuba ma'am, and Dr. Vijay sir for an excellent panel we had. I really feel we had a very great discussion right now, and I believe no conference is short enough for this discussion to go on. And with the paradigms we are changing right now, newer and newer therapies tend to come in and tend to have their influence on it. We have a slight delay. Dr. Amish Vora might have been occupied in some parallel discussions. So may I have the honor of inviting Dr. Novak sir for his lecture, which will be followed by the panel discussion by Dr. Amish Vora sir. We do have Dr. Novak sir with us.
Good afternoon. Hello, Dr. Vikas.
Wonderful, sir. So
yeah. I cannot start my video. It's saying the co-host has stopped your video because or should I start? I'll share my screen. I think my video is not there. Hello.
Yeah,
Perfect.
We can hear you, sir. We can absolutely hear you. You can make it on a slide mode, presentation mode, okay, sir. Over to you.
Okay. Good afternoon, everyone. I'm Dr. Novak Gupta, medical oncologist from Faridabad. So first of all, thank you, Dr. Vikas. Thank you, organizers, for this opportunity. That wonderful topic given to me today is optimizing treatment for recurrent metastatic squamous cell head and neck cancers with immune checkpoint inhibitors. These slides have been given to me by BMS. So we're all aware that our head and neck cancer patients we are all aware that our head and neck cancer patients, they do have a major psychological, social, and physiological impact. The disease has a huge impact on our patients. The patients often complain that they have difficulty to breathe, to swallow. They do have a lot of side effects because of the radiation, the chemotherapy, the weight loss, the dermatitis, the mucositis. So we as physicians have a huge role to play in the management of our patients. We have our treatment algorithms in place, but we need to discuss all our patients in the multidisciplinary team and decide what is the best treatment for every individual patient. So, in order to decide for the best treatment, we really need to listen to our patients. We need to discuss with our colleagues what would be the best treatment. We need to know the data. We need to get all the information and then eventually, decide what would be the best treatment for our patient. So be it NCCN or any other guidelines, all the guidelines recommend that a multidisciplinary team is very, very essential for the management of head and neck cancer patients. Now, multidisciplinary team would include a number of people, which would include the surgical oncologist, the radiation oncologist, the medical oncologist, the plastic surgeon, the specialized nursing care, the dental surgeon, and all these, the nutrition, the pathology, the radiology, everyone should be a part of the multidisciplinary team to get the best outcomes for our patients. Now, talking about the disease burden, head and neck cancer has a huge disease burden. It accounts for approximately 20% of the cancers in our country, with about an incidence of more than 2 lakhs. Now, head and neck cancer has a huge unmet need. Why so? Because we are all aware, we have discussed that most of the patients, approximately half of the patients, relapse, and that happens in the initial 2 years only. Another big problem is that more than 50% of these patients, they present to us with a locally advanced disease. About 10% of the patients present with a metastatic disease, and the survival is then very less. Now, when we're talking about locally advanced disease, surgery and concurrent chemoradiotherapy is absolutely integral. Now, single agent cisplatin is the standard of care and has been the standard of care when we talk about concurrent chemoradiotherapy, be it the definitive or be it the adjuvant setting, the dosing, the 3-weekly or the weekly based upon the institution or the practicing medical oncologist, but by far single agent cisplatin has been the standard of care. Now, the problem is the outcomes of the patients who have a recurrent or a metastatic disease is poor. And especially the patients who progress when they have been treated with platinum-based therapy. So now, talking about head and neck cancer, the squamous cell head and neck cancer is something which is an immune suppressive tumor. Now, we are all aware that these malignancies, they have a low CD8 count. The CD4 is the Th2 phenotype. The tumor-associated macrophages also are impaired. A number of soluble factors like the TGF-beta, the VEGF, IL-6 and 10, and all these lead to T-cell death. The T regulatory cells, the NK cells, the dendritic cells, they are all impaired in functionality. So by far, this is an immunosuppressive disease. This is an immune suppressed disease. Now, what is Opdita or nivolumab? This is a fully human IgG4 PD-1 receptor blocking monoclonal antibody. Now, the drug inhibits the immune suppressive mechanisms directly at the tumor site. It prevents the inactivation of the T cells and also reactivates the T cells, enabling them to attack the malignant cells. It binds with high affinity to the PD-1 receptors on the T cells, and it thus inhibits the signaling of the PD-L1 and the PD-L23. and that by far enables the T cells to, to restore their anti-tumor activity. Now coming to this Checkmate 141, the Checkmate 141 was published in 2016 in NEJM. Today, what we'll be discussing is the 2-year update, which was presented in 2018 by Dr. Ferris. So this is the trial design. We are all aware of this. This was a randomized open label phase 3 trial of the patients who had a recurrent metastatic squamous cell head and neck cancers who had progressed on or within 6 months of a platinum-based therapy. The inclusion was the patients who were not amenable to curative treatment, who had progressed within 6 months of platinum-based therapy, had a good performance status of ECOG 0 or 1. The inclusion was irrespective of the PD-L1 status. Now, these patients were randomized 2:1 to receive either Opdita or investigator choice regime. Nivolumab was given at a dose of 3 milligram per kg every 2 weekly. There were about 360 patients and 240 in the nivolumab arm and about 121 patients in the investigator choice arm. The investigator choice treatment was either methotrexate, docetaxel, or cetuximab. The primary endpoint was the overall survival. The other endpoints was the progression-free survival, the overall response rates, the duration of response, the safety, the biomarkers, and the quality of life. Now, these are the patient characteristics we have. We can see the baseline patient characteristics are very well matched. Okay, so now this is what is important. Why is the Checkmate 141 data important? Because it's quite relevant in our setting. We can see the various subgroups, be it the HPV status, the age, the quality of life, the prior cetuximab use, which was discussed in the previous session, the best overall responses, the first line recurrent metastatic subgroups, and the Asian subset of population. Now, this is the overall population, the IDD population. We can see over here that the Kaplan-Meier graphs start to separate at about 3 months. The 24-month survival is 16.9% with Opdita as compared to just 6%. The median overall survival being 7.7 months, and with the investigator choice, it was 5.1 month and a hazard ratio of 0.68. So this would mean that the patients who have been treated with Opdita, approximately every one patient in every 6 patients would be alive at 2 years as compared to 1 in 16 patients. The second thing is what is, I think, even more important is the duration of responses are also very high in the patients who have been treated with Opdita, with a median duration of response being 9.7 months as compared to 4 months in the patients who have been treated with Opdita versus investigator choice. Now, the median time to response also is similar with Opdita and in the investigator choice. So this is something we sometimes do have the apprehension that the response rates might be slower when treated with immunotherapy as compared to the chemotherapy. Now we would talk about the subgroups, the various subgroups. The first is the PD-L1 expression. Towards the right, we can see the patients who had a PD-L1 of 1% or more. Not obviously, these patients had a much higher overall survival with 8.2 months versus 4.7 months and a hazard ratio of 0.55. But what is more important to me is if you see the patients who had a PD-L1 of less than 1%, even in those patients, the median overall survival is 6.5 months versus 5.5 months and a hazard ratio of 0.73. So all the patients get benefited with Opdita irrespective of the PD-L1. Now, what were the set of the patients who were included in this? The patients who had a disease progression when they received induction chemotherapy with a platinum-based agent, the patients who progress on definitive chemoradiotherapy within 6 months, or the patients who progressed within 6 months after the adjuvant concurrent chemoradiotherapy. Now we see these patients when they received Opdita as the first line in the recurrence settings, there were about 78 patients, or accounting for about 21% of these patients. We see this set of patients, we have quite interesting data for these set of patients. Now, this is the set of the patients we'd be discussing. Yeah, there were 78 patients or 21.6 patients. So of these, 52 received Opdita and 26 patients received chemotherapy. And they had progressed after platinum-based therapy in the primary or the adjuvant setting. Now this is, but even though this is a post-hoc analysis, but the data is quite promising. If in this set of patient population, the median overall survival is 7.7 months in the patients who received Opdita as compared to 3.3 months who received chemotherapy with a hazard ratio of 0.54. The 2-year, 24 months overall survival is 21.6% versus 3.8%. Now this is 5 times more in the patients who received IO as first line as compared to the patients receiving chemotherapy. And there's a 46% reduction of death in this set of patient population. Okay, now if we see the responses. So the overall response rate was 19.2% in the group receiving Opdita as compared to 11.5%. 2 patients had a complete response and 8 patients had a partial response versus 0 patients having a complete response and 3 patients having partial responses in the chemotherapy arm. The last is the time to response is 2 months in both the arms. Okay, so the next thing is the quality of life. If we see the quality of life, which is by far, I feel very important, especially when we are talking about head and neck cancers and the palliative settings. So be it the physical functioning or the role functioning or the social functioning, the treatment with nivolumab improved all the quality of life parameters as compared to the chemotherapy, which deteriorated over a span of time. The second thing is the symptom burden. Symptom burden again is I think very, very important, especially in the palliative settings. So treatment with Opdita was, it led to stabilization or improvement in the symptomatic burden of the patients as compared to the chemotherapy, which eventually deteriorated. So be it the fatigue, the dyspnea, the appetite, decreased appetite, all the parameters improved or at least stabilized when treated with Opdita. Similarly, if we see the other, the symptoms like the pain, the sensory problems, and the social problems, all these parameters were either stabilized or improved on treatment with Opdita as compared to chemotherapy, which mostly deteriorated with time. So the next thing is, if we see the patients who had a complete or the partial response. Now, these are the set of the patients. We're all aware that the patients who do respond they do extremely well. So these are the patients. If we see this set of patient population, the median overall survival was not reached in the patients in the Opdita group as compared to 13.6 months, and the hazard ratio of 0.12. A dramatic, very amazing hazard ratio of 0.12. 18-month survival rate of 86% versus 38%. Now these are the patients who do extremely, extremely well. The patients who achieve a CR or a partial response. The next set of patient population is the patients with a stable disease. Even though the stable patients with stable disease, we can see the graphs are separated apart. The median overall survival again in these two patient set of patients is the overall survival is 10.4 months versus 7.1 months with a hazard ratio of 0.53 and 18 months survival rate of 32.6% versus 11.7%. So even the patients who do have a stable disease are also getting benefited on treatment with Opdita eventually.
Sir, a small request. You have 2 minutes to conclude, please.
Oh, okay. So this is what I guess Dr. Naresh Somani and my professor were discussing priorly. So this is the the subgroup analysis of the patients who had a prior cetuximab and the patients who did not receive a prior cetuximab. So the patients who received, both the set of the patients benefited, but the patients who did not receive prior cetuximab benefited much higher with a hazard ratio of 0.52. So this is the set of the if you see the age, both the groups benefited at the hazard ratio of 0.63 and the hazard ratio of 0.75. Similarly, if we see the patients, irrespective of the HPV, the hazard ratio is almost. So now, next is the the Asian set of population is again, I think, very important. The Asian set of benefited in a much better way as compared to the ITT population. The overall survival being 12.1 months as compared to 6.2 months and a hazard ratio of 0.41. Now we have the forest plot. All the subgroup and patients are getting benefited with Opdita as compared to chemotherapy. All data, the drug is quite very well tolerated. They were just over about just 15.3% grade 3, grade 4 adverse events as compared to 36.9%. Now, these are the common adverse events. The fatigue, nausea, anemia, asthenia were the most common adverse events. They were not much grade 3, grade 4 events. Skin toxicity is the most common. So by far, starting early with nivolumab, preferred monotherapy post-treatment. Nivolumab is the first and the only monotherapy which is approved in India in the recurrent metastatic. Now the patient's assessment, initial assessment should be done after 9 weeks, and then every 6 weekly the treatment is continued until disease progression or treatment-related toxicity. So to summarize, head and neck cancers have a major psychological, social, and physiological impact on our patient. Multidisciplinary team is very important for our patient. Nivolumab has shown a survival benefit in the patients who have had platinum-based treatment and have progressed. The magnitude of overall survival is 5 times much more in the patients as compared to chemotherapy in the first-line setting. Opdita gives a good quality of life and symptomatic relief in the patients as compared to chemotherapy. In the Asian subgroup, the drug has demonstrated a significant 59% reduction in the risk of death as compared to the chemotherapy. So we have a small, I'll just rush through it. 2 cases, small cases. 61 years old male who's a smoker, HPV positive, has medical renal disease. He was diagnosed with stage 3 squamous cell carcinoma of the tongue. The patient was initially stable after initial platinum-based treatment, but the disease recurred within 6 months, and the patient is now platinum refractory. He has a good performance status. So, what would be the ideal treatment? I guess anyone, Dr. Vikas or anyone just. So what would be the ideal treatment for this patient or? Hello? So, okay. I think be it the age or anything, immunotherapy can be a very good option for these patients, especially in the patients who are platinum refractory. So we have one more case, just a 59 years old, a female patient who's a smoker. She's symptomatic with hoarseness of voice and difficulty in swallowing. Was diagnosed with a CL larynx. T2N2B was, received CTRT with carboplatin plus paclitaxel. The patient recurred after about 13 months and had a lung and liver mets with a deranged LFT. So again, ideal, any the number of factors can be taken into consideration. We've discussed this in the panel previously. So yeah, IO is something which can be really offered and would be helpful. So now the drug is approved for a dosing over a just 30-minute span, quite convenient for the patients, shorter infusions. And so with this, I'll conclude my session. I think I've done honor to the time.
Thank you. So thank you so much. Thank you, Dr. Novagupta, for such a wonderful presentation. Yes, of course, on time. Thank you so very much. There's a shortage of time. We move to the next presentation. So can we have the panel discussion now? If you allow, Dr. Vikas sir, can we have the panel discussion now? So Dr. Amish sir, are you available?
Yes.
So very, very good afternoon. And we welcome you, to conduct the panel discussion. And by the time you set your slides, we would like to have your panelists in place. It's a pleasure and to welcome. So first of all, it's a pleasure to welcome Dr. Amish sir, Director and Co-founder for Hope Oncology Cancer Clinic in Delhi. We request Dr. Vijay Patil sir to come back again, Professor Medical Oncology at Tata Memorial. We request Dr. Akhil Kapoor, Assistant Professor Medical Oncology at Tata Center, Varanasi. And of course, Dr. Anuj Gupta, Assistant Professor Medical Oncology from Tata Memorial, Varanasi. And we also like to have Dr. Vikas Talreja, Consultant Medical Oncology from Regency Hospital, Kanpur. So your panel is packed. Over to you, Dr. Amish sir, for your deliberation, please.
Thank you so much. And I will try to finish in 25 minutes, Tarun, or 30 minutes.
So you have a full 30 minutes, so please,
Okay.
all yours, sir.
So let me know when I have 5 minutes left. Okay.
Sure, sir, sure.
Okay, thank you. I can see Dr. Akhil. I can see Vikas in a nice beard. And Dr. Arun, do we have him?
Yeah, Dr. Anuj is there, and we also have Dr. Vijay Patil sir.
Dr. Vijay Patil. Dr. Vijay Patil, how are you?
Chal raha hai, sir.
And Dr. Anuj, can you put on your video? Okay. Yes, Vijay, I can see you. I can see Akhil. I can see Vikas, but I'm not seeing Dr. Anuj. Anyway, I'm sure he must have joined and he will do when we say. So changing paradigm in head and neck cancer is the topic which Dr. Vikas has given me. And he is also one of the panelists. So this is, very, very interesting. NCCN guidelines version 1 2022. Preferred regimen, you see the first line is either pembrolizumab alone or pembrolizumab with chemotherapy, and other recommended, we have cetuximab platinum, that is category 1. So there are 3 category 1s what we have in the first line. 1 year back, if you see 25th of June, this report is there. Merck had submitted, please consider pembrolizumab in the treatment of advanced MSIH head and neck squamous cell carcinoma. They got yes. But if you see that the other one where right now just 1 year they are category 1, they were vetoed out 24-0. Not a single vote they got for including in the first line. And in 2022 January, we have them as category 1. So this is in real sense is a changing paradigm which is there. So what I'm going to do, I'm going to do little ulta. I'm going to just narrate the case and then we'll see what all could have been done. So this is a 64-year-old male diagnosed with vallecular cancer in 2020, unresectable disease to begin with. First line chemotherapy with cisplatin, 5-FU and cetuximab. Post 3 cycles, there was a good partial response. 6 cycles and then stopped. We don't know why stopped. 5 months later, there was a progression and there was a symptomatic progression to spine and brain, and the radiation to both was given. On progression, the second line nivolumab was given. Dr. Novak has given an amazing talk about nivolumab, Checkmate 141. Second line nivolumab was given 3 doses. I don't know why patients stopped treatment again after 4 months. There was no scan done. After 3 doses, 4 months later, patient had progressive disease. That is a time when patient came to me. He didn't want any treatment at that point of time. He had met Dr. Anil Dekru sir also. I counseled the patient, performance status was almost 0. So I said, why are you giving up on your life? We started with nab-paclitaxel and carboplatin. 9 weeks later, there was a very good response. CPS PDL1 was not done. So I got it done and it was exactly 1 from 2 different labs. PET CT was done after 4 cycles. There is a pseudo progression right now, but patient is amazingly asymptomatic and with a very good, decent quality of life. So I have continued on pembrolizumab plus chemotherapy and I'm waiting for the next scan. So this is where we are right now. So let us do the reverse engineering. Dear friend Vikas, and followed by Akhil. Would you have treated this patient differently in 2022? We start with Vikas and then we go over to Dr. Akhil.
Would have managed in the similar lines, just would have got a CPS score done on the first visit only, because if affordability is not an issue, then probably pembrolizumab I would have sequenced a bit earlier, because he would have avoided probably, as we could see that he had progressed and that's why he defaulted. So whenever the patient doesn't come, probably you could see those loss in the faith in the treatment per se, especially in the head neck cancer. So whenever they progress, they feel demoralized, they feel.
You would start, if CPS 1, you would start with immuno plus chemotherapy in this patient.
Yes.
Okay. Akhil?
Yes, sir, definitely agree with this statement. And pembro plus chemo is a good option, as it was discussed in the last panel discussion as well. But one thing, there is something called patient preference as well. A lot of our patients, they tell that I don't want IV chemotherapy or even any IV treatment. Then we always give them option of triple metronomic. But definitely I agree. This is after discussing other options when the patient is not agreeing for the IV treatment. So I completely agree with the treatment till now.
Okay, perfect. Dr. Vijay Patil, what is missing in this case?
Well, I think multidisciplinary discussion is missing in this case. This case was a vallecula 64 unresectable. In the first situation itself, I would have discussed with my radiation oncologist whether this patient would have been fit for radical CTRT. At least after giving NACT, when there's a good PR, I would have definitely subjected this patient to a radical CTRT. I would have done that.
So it was discussed and radical CTRT also was not possible. The patient's disease was, close to, there was a supraclavicular lymph node, there was occipital lymph node, and this patient's radiation was not possible. That was what it was. Right. But your point is very well taken, that I should have mentioned that it should have been that. Okay. Dr. Anuj, are you there?
Yes, sir, I'm there.
Okay, perfect. So Dr. Anuj, I was reading this principles of systemic therapy for non-nasopharyngeal cancer. And they have written next generation sequencing may be considered to guide patients. Head and neck cancer, next generation sequencing upfront. How commonly are we doing it? Are we following this particular NCCN guideline point?
Sir, frankly speaking, we are not at most of the centers, and at our center also, we are not upfront usually going from NGS, because we are only doing the PDL1 testing for giving the immunotherapy or counseling them. We are not doing this NGS testing routinely, but it should be done because we may get other targets for the therapy.
Other targets. Dr. Vijay, would you agree with Dr. Anuj?
Yeah, I agree. For all, if I get an affording patients, I do it routinely. I give that option to every, yes, for affording patients.
So Vijay, what would NGS say this particular patient is for palliative chemotherapy? What would it change based on NGS report? Give me an example. Give me an example.
Yeah, I'll give you an example. So if it shows an HLA mutation, we had data from last ASCO about good with tiplafenib. If it shows an NTRK mutation, which are known in head and neck cancer, so then I would have used lacrotinib. Second thing is the genomic landscape data that does show that in 2% or 3% of head and neck cancer, you can get macrosatellite instability. If that data comes, I am very happy to give pembrolizumab. So, and you always get, you would also have seen this, you always get surprises. You might come up with an EGFR exon 20 deletion. So you get these surprises. And actually what has happened is head and neck genomic is an unexplored area. So there is, I think if the patient is affording, he doesn't have any resources, there is no harm in getting it done, because you are going to get, sir, for example, I'll give an example. A few years back, ALK we used to do when there was 3% chance. Now for 2 or 3% macrosatellite instability, some NTRK, some HRAs, other mutations, I feel comfortable doing it.
Vikas, I, as a moderator, tend to not agree with Vijay, but I always get afraid when I don't agree with Vijay, because MSIH can be done on IHC also. Do you think right now in 2022 January, are we at a stage where NGS can define first-line treatment in metastatic unresectable head and neck cancer?
Sir, if we dissect your exact words, I would say that no, it is not. But then again, we know when we are treating metastatic head neck cancers, we are running out of options. So
first line, I'm talking of first line.
First line, again, we know that they are going to fail within 5 to 6 months, at best 7 months in due course of time. So we have to also find out the alternative options at the same point of time. Dr. Vijay pointed out very important mutations for which we have targets for it. The NTRK, similarly, I tend to do, whenever I tend to give that expensive immunotherapy injections, I also tend to do the NGS testing, because it's not going to be available within 1 day or 1 month, or it takes at least 3 to 4 weeks, good turnaround time for that NGS report to come. And by that time, if we know that our therapies aren't working, we have an option to discuss with these patients. A classical example, I would say that we have found STK11 mutations, again, giving that bad pembrolizumab and then finding out that STK11 mutation was there and it wasn't supposed to work to start with. I believe it's a Pandora box that
I agree with you, Vikas. And, when Vijay said that, I agree with both of you. I have been looking at these mutations. Unfortunately, they are not sine qua non of not responding to immunotherapy. They may not respond to immunotherapy, but not. So I would, so there is point is, yes, we are offering pembrolizumab, we are offering cetuximab, and I'm sure all of them can afford NGS. So for our future reference, yes, point well taken. Akhil, you would do NGS upfront or in future? Just one line and then you can answer this question, that would this patient should have continued on cetuximab maintenance?
Yes, if feasible, would like to done upfront, because yeah.
Okay, and would you have continued cetuximab maintenance in this patient? They stopped after 6 cycles.
No, I would have continued.
You would have, see, there is a no-brainer. Patients should have continued with cetuximab. Since I have reversed, let me ask Dr. Anuj this question. This patient has received nivolumab 3 doses. Then patient was lost to follow-up. I again gave pembrolizumab. We don't know what was the response at that point of time, but when patient came to me, patient had progressive disease. Would you have given immunotherapy again in this patient?
Definitely, sir, because after the 3 cycles of nivolumab, we didn't do any response scan. So we don't know what was the response to the immunotherapy initially. So definitely I would challenge it with the pembrolizumab or nivolumab in again when the patient comes to us for the further treatment.
Okay, perfect. So you would have given this. Dr. Vijay, before we jump onto this question, I wanted to ask you, do you re-challenge with immunotherapy in head and neck cancer? And if yes, which are those patients?
So the issue is that most of my experience in immunotherapy comes from ongoing trials which are ongoing. So so most of the times patients or my patients will be very clear here that are credit patients from or whose insurance are providing them. So most of the times the immunotherapy continues till progression. So I get what you're trying to tell, and what you did. Probably if this patient would have come to me, I would have done the same thing of re-challenging with pembrolizumab. So what I would use is go with the oncological principles. That okay, last regimen was used. You didn't know what was the response to the regimen. They stopped the regimen. Then there was a progression. There's a pretty good immunotherapy free interval. I would like to take it as 6 to 8 months. More than that, I would re-challenge. But I don't have uphand experience like 100 patients में nivolumab पहले मिला था, बाद में 30 में दिया क्या. I don't have that data with me.
Correct. None of us have that, but there are some trials going on for immunotherapy re-challenge, and I'm waiting for the results. Dr. Vijay, just, TPX is a phase 2 trial, but it has been extensively discussed. So extreme or TPX, forget about immunotherapy for a time being, let's talk of these two regimens.
If you are going to give me only these two choices, my choice is going to be TPX.
Your choice is going to be TPX. Vikas, you would agree? No PICC line, no admission, only 4 cycles and done with it, or you would want phase 3 data?
I totally agree, sir. Simple regimen for probably, I would say, avoiding the 5FU based regimens, and also based on the molecular. We have DPD mutations in most of our patients. We have to further modify these doses, and then take a hindsight that whether we should have given the 5FU or not. So
I completely agree. That is one major problem of 5. In fact, lately, last 2-3 years, I am seeing a lot of small side effects of 5FU, and I wonder, is the manufacturing defect is there? But I'm seeing loads and loads of small side effects.
I would agree with you that, sir. We used to see that.
Vijay, so organize a conference where we discuss on 5FU side effects. And
we would used to get a manufacturer gets changed, and the cardiac events used to start occurring.
I completely agree. I'm so tired of these 5FU side effects, which I have not seen in last so many years. Akhil, Keynote 048, would it have been different if the comparator arm would have been TPX? Nobody knows, but just wanted to ask.
Not sure, but the thing about TPX is that even when phase 2 data was not there, we were using TPX in our practice.
Correct. Absolutely.
And that was not only our practice, even in US. Vanita ma'am had put a question on the Twitter, and everybody responded they are using TPX, even when TPX data was not available.
You're absolutely so right, Akhil. I don't remember last when I have used Extreme. I have been using TPX. Even before TPX, I have discussed in so many conferences, but I have been using before that. And the reason is, evident on this slide. It is very crystal clear. Compliance is good. Maintenance is good. Even progression is better. And median OS is slightly better. In addition to that, we also have the data on that. So Akhil, let me come back to you. Which patients in your practice you would not consider for immunotherapy, irrespective of PDL status?
Very high disease burden, patient very symptomatic, PDL1 status not known, I will use.
PDL1 is 2%, for example, but you would still not consider for immunotherapy.
Only when there is clear contraindications of immunotherapy.
Clear contraindication of immunotherapy, please name them, and how commonly do you see in your clinical practice? Because remember, everybody said that first line CPS 1 or 2, they would go for pembro plus chemo.
Yes, in real practice, we don't see any real patient who has actually very strong contraindication of immunotherapy. Most of the time, the autoimmune diseases which are there are also controlled with the available treatment options. So I don't see any strong contraindication to use of immunotherapy. If PDL status, if it is very low, 1% or less, I would be tending towards using of TPX more in practice. Disease burden very high, I will be preferring the TPX. But in other situations, pembro plus chemo is the most commonly used option. And as discussed, if frail patient, high PDL1 can use pembro alone.
Pembro alone. Vikas, you would agree with every word Akhil has said, or you would want to add something?
Totally agree. The only
patient has kidney transplant done in the past, would you go for Keynote 048?
Sir, if he is on steroids and there's also DEXA, I believe there is no harm in giving the immunotherapies, because by far it is one of the lesser toxic devil. If we have to symptomatically manage, I believe I would definitely go ahead and give the therapy. The only reason, apart from what Akhil has enlisted, is the finances, which always come into our play. Otherwise, pembrolizumab should be coming more than PD-L1. The CPS score more than 1, I would always
So with the PAP of pembrolizumab, because pembro and cetuximab almost more or less turns out to be the same. So fortunately, in this particular instance, we don't have to, anybody who can afford one can afford another. Anuj, before you go, the bottom what I have pointed is the exclusion criteria of Keynote 048. Okay, then I will read that if they had progressive disease within 6 months of curatively intended systemic treatment for loco-regionally advanced disease, they were not considered for Keynote 048. 5 mahine baad CTRT ke after 5 months, if the patient has progressed, would you go for Keynote 048 if CPS is 5%?
Sir, that
we
will
don't
again,
have the data.
It will depend on the disease burden actually, sir. If the disease burden is low, then I would consider it. Otherwise, I will not consider the immunotherapy.
Dr. Vijay Patil, if we strictly go by exclusion criteria, 4 months, 5 months recurrence after CTRT, we don't have the data because that was the exclusion criteria in Keynote 048. Would you go for immunotherapy in these patients? Dr. Vijay.
In my regular practice, I always classify this. If the patient has failed within 6 months of last dose of platinum, for me, it's platinum refractory. So there is no question of treating at first line. I would go with the Ferretz data for nivolumab or Cohen's data of pembrolizumab. I won't even bother to look at the PD-L1 status for selecting. If the patient wants to know how much benefit is going to win, then I would do the PD-L1 status.
Okay.
So these patients were even excluded from the extreme trial. So this was not an extreme also.
I had exclusion criteria of extreme trial, and I couldn't find. But I will not challenge you for extreme data. But I
believe me, sir, this was excluded.
Okay, I couldn't find it probably. Akhil, you would agree with Dr. Vijay?
Sure, Dr. Amish, sir, last 5 minutes to conclude.
Perfect. Done. So I think, let's move forward because I have 1-2 more points to discuss. This is never ending. What I would do is I normally in my practice nowadays, last 5 years, have started strictly following inclusion and exclusion criteria based on which we are going to decide patient's life. Of course, there can be a gray zone, 5.5 mahina or 6 mahine mein bahut farak nahi hai. But otherwise, sort of I try to do that in my clinical practice. Because quickly, which patients you would not give cetuximab? I'm talking of contraindications of cetuximab.
Again, I believe those patients where you have a PD-L1 documented of more than 50% or a good PD-L1 CPS score.
So CPS more than 20, we are not talking. We are talking of cetuximab contraindication. You want to give cetuximab to this patient, but you couldn't give.
Probably none.
Probably none. That is what I would also agree, that it is probably none. Dr. Anuj, you agree with this chart, which, this chart has been provided to me by Merck, and you agree with this, that this is how we have gone forward?
Yes, sir. I completely agree because this TP-Extreme data has shown that the benefit gain was around 14 months with this, and with the given landscape, we can see how the treatment has evolved with the increasing benefit in terms of survival. So I completely agree with the chart, sir.
Akhil, help me understand when we have this data. See, in Keynote 048, 14 to 15% of patients in extreme arm went on to receive immunotherapy. We do not have data for another 85% of patients. They were given some other chemotherapy. Okay. In TPX, we have this data. Why not reserve immunotherapy for second line? And Checkmate 141 was shown so beautifully by Novak. What is stopping us from, doing this? You see, what I love about Checkmate 141, the 15% of patients who responded, they continue to respond over 3, 4, 5 years also. Akhil.
Yeah, sir. So I agree that immunotherapy activity is like a jackpot. Those who get it will get the maximum benefit. But I again will tell that 70 to 80% will not benefit. So we give the choice to our patient and let the patient decide. That is the best option that we need to give to our patients. That on one side we have surety that at least 50 to 60% patient will have some response, but how much durability it will be, we are not sure. And on the other hand, we have durability of response in around 15% patients.
Vijay, you know, somewhere I get frightened by pembrolizumab monotherapy, but of course, if there is CPS 50%, we are supposed to offer. But you know, like as Akhil said, it is like a jackpot. We still do not have NGS signatures.
I agree with that. If the patient is elderly, if has minimal symptoms, then only I would offer single agent pembrolizumab. I am actually afraid about not about the responses, but about the progressive disease,
correct,
which is much more there with pembrolizumab. So if the patient has bulky disease, is symptomatic, I don't take chance. I would give pembro plus chemotherapy to the patient.
Perfect. You know, as somewhere pembrolizumab monotherapy, I get afraid of that. And this would be sort of my last slide. And I wanted each and every 4 of you of this comment. And this occurred to me when I read results of Cleopatra's 7 years of data, and Senthil Rajappa and I were arguing about it. I said, trastuzumab plus, you know, pertuzumab, 33% at 7 years. And he said, Amish, don't forget, 25% were on trastuzumab alone also. So similarly, if you see the cetuximab plus chemotherapy, 19 to 22% is consistent across the group. Who are these 1/5 of patient, starting from Vijay?
I don't know, sir. Who are this 1/5 of the patients? I think that if someone discovers that with a genomic signature, it will change the way we treat the patients. Because,
so true.
Yeah.
Anuj?
Sir, I don't have answer to that question, sir.
Actually, none of us. Because, so, you know, there are some patients who are going to do well on cetuximab. As Akhil said, there are some patients who are going to do well on immunotherapy. But you see, there are 20% of patients continue to do well on cetuximab. Who are these patients? Any idea in your clinical practice?
There is a catch also. When you see the extreme 5 years data, that those curves were not that good. And in this, there is some amount of reciprocation by receiving immunotherapy and pembrolizumab. So that 22% of cetuximab is not only contributed by cetuximab, as was very well showed in the previous slide, that also is contributed by the second line immunotherapy, which this patient
Absolutely right, Vijay, absolutely right. You know, we are talking of the second line and third line also. OS data is purely and purely based on second and third line. I completely take your point. Vikas.
So we have 2 beautiful drugs. We should be challenging them. And I believe that's where it's the jackpot that the patient might hit, that if the pembro doesn't hit, we might give him another jackpot of giving cetuximab. If cetuximab doesn't hit, then we might give them the jackpot of hitting the pembrolizumab. But we should be discussing that if either of these work, you will have a 20% chance of surviving up to 5 years, which wasn't probably 5 years back, I would say.
Right. Akhil, in your practice, have you given cetuximab after immunotherapy?
Amish, sir, last 1 minute, sir.
Yes, this is the last point.
Yes, sir. Definitely. We have used it frequently, actually. So despite we don't have very good data, but definitely we have used cetuximab after use of Keynote 048 as well. So we have seen good results. Some patients do really well, as pointed out Dr. Vikas sir as well. It is feasible and possible. And also working on the genomic signatures, that's the way forward. And we are looking forward to a collaboration with an Italian team where they are going to work on the genomic signatures of head and neck cancers. So
अखिल, वाराणसी में आरती बहुत अच्छी होती है, बुलाओ हम सबको और NGS signature सिखाओ. With that, Tarun, over back to you, and thank you so much for inviting me for this session.
So thank you so very much, Amish sir and the esteemed panelist for this wonderful discussion. Now we move to the next, and this is a talk. And so we request Dr. Vijay Patil sir to stay back. And as everyone knows, sir is a professor in medical oncology from Tata Memorial. Dr. Vijay Patil sir is going to speak on evidence-based guidelines on nasopharyngeal cancer. Sir, over to you. Vijay Patil sir, over
Okay,
to you.
I'll just share my screen.
Sure.
I hope it is visible.
Absolutely, sir.
Okay, so when I got this invitation, I thought that what to focus on. And you will be surprised I have not focused on induction chemotherapy because I don't think there is any need to more bombard that induction chemotherapy is important in nasopharynx. So I have focused it on multiple things. So the first is nasopharynx. Most of the times you would have good lymph nodes around, and you would have some amount of people would say, oh, why do you need a biopsy to be done? And I think it's important that, okay, you can go ahead with an FNA from lymph nodes, but I think biopsy gives you better things. It gives you grade. It tells you in cases sometimes the patient presents only with lymph nodes, presence as unknown primary. It helps you to getting a diagnosis. And I also believe that it helps in the first line, even in the initial setting itself, to give EBV analysis done on the blood. It is a good prognostic marker. PDL1 MSI mutation analysis, if it is affordable for the patients, I think this is one information I always like to have, because what I've seen in my experience in head and neck cancer is that when the patient recurs or relapse, you actually can't wait for those 15 to 20 days or 30 days to get those reports. And second thing is a very practical thing which I've seen is that nasopharynx actually relapses a few years after that, like 3 years, 4 years, 5 years down the line. At that time, most of the times the blocks are misplaced or the DNA from the tissue is inadequate to get any reasonable thing from. So this is the evidence supporting that. This is from 2021 from meta-analysis, which suggests that Epstein-Barr DNA analysis at baseline leads to benefit. PDL1 expression in nasopharynx is actually very high. It's reported in 90 to 95% of the papers. In this paper from Zhang, it is reported in 70% of patients. Now we have quite a bit of data sets from Tata itself, and this data sets of 1,000 patients, and you could see that this is negative. So in RA, at least 70% of patients have this, and this is TPS, not CPS. So CPS will be better than this. 70% of patients have expression. This was the data which I was talking about, that macrosatellite instability you could get in around 2% of patients in head and neck cancers. This is the data I was talking about. It came in the science reports a few years back that if you taken together this important pathways which have potential to get targeted, like EGFR, PIK3, mTOR, Notch, DNA, you would get 72% of mutations in and around these pathways. And I'm sure in future we would have much more things. Along with that, I think it's important when we do workup that this is one place where I would like to get both an MRI and a PET-CT done. MRI because the soft tissue components traveling along the nerves for nasopharynx is important in radiotherapy planning, and it's important to explain the symptoms of the patients. This is one side in head and neck cancer which has predisposition for metastasis. So distance metastasis is quite must for T2 plus. You would find it in like 15% of the patients. If you do scans, you would find their metastasis at presentations. And the reason why I would prefer PET-CT over a CT thorax here is the reason being that bone metastasis in this peculiar head and neck cancer is common. So I would like to have a look at the bones also in this. And if I'm ordering a PET-CT, I would order the CT component of the PET-CT to be a CE-CT of head and neck cancer, so that even that helps me and my radiation colleagues with planning. I think it's important that when you plan a nasopharynx, there will be two groups of patients here. One would be those who are adolescents, one will be elderly. So looking at fertility preservation, looking at how well the pituitary hypothalamic axis is working, how well the ophthalmic perimetry getting, these things are important, especially if the tumor is T4 and plus, or if it has
some amount of extradural or intradural extensions. This is must because subsequently post-RT, post-treatment, quite a few times you get that these patients are not growing well, there are hormone deficiencies, and you don't know what the baseline is. So it's recommended by NCCN, and at Tata also we follow. Dr. Sarbani is actually very strict about this, that all pituitary hypothalamic, we get an endocrinologist workup done for these patients, get an PAL evaluation done for these patients. It's important that we get an audiometry also done for these patients. Most of the times you are going to see a hearing loss, and it would be conductive hearing loss. What we are interested in looking at is a sensory hearing loss. So as I told you, I would be taking this reverse way. I will more talking about recurrent and metastatic nasopharynx, because that really does not get discussed that much. Our focus gets limited to the locally advanced case. So this is a site in head and neck cancer where if you have oligometastatic disease, you would have an option of offering these patients curative form of therapies. So what we do at Tata is we routinely give neoadjuvant chemotherapy in the session, look at the response, take it to a multidisciplinary clinic and discuss with the radiology colleague and radiation colleagues and decide about the further course of therapy. If it's widely metastatic, then it comes for systemic therapy. The question is what is the way it is? It is different from other head and neck cancers. Other head and neck cancers, you would see that it is mainly local regional and some amount of distant metastasis. Now, this is not the case in nasopharynx. The failures, especially after introduction of IMRT, the natural history of this disease has changed. The failures are more distant, and the failures are multiple times, multiples which are in multiple organs which you are going to see. So in most of the patients, systemic therapy remains an option. And we have data from Tata now that varied is the expectations of the patients. I really don't think that there is one standard of care for all patients. It is about, even when we say that science should not be discussed according to finances, the reality is that you cannot pick a patient out of his socioeconomic background, his support system. And we do that routinely, and it's important that we acknowledge it academically also, that the patient needs to be seen in this whole compartment and decide the treatment. What do we give? Cisplatin 5, so extreme trial, cetuximab never enrolled nasopharynx patients, so that question is out. We are still with chemotherapy in nasopharynx. What should be the trial? So cisplatin 5 is to be the choice, recommended in most guidelines, though we don't use it. There was a head-to-head trial of cisplatin 5FU versus gemcitabine cisplatin. It did show that gemcitabine cisplatin gives good survival advantage. And I want to point out, we are talking about here metastatic, and look at this 36 months control here. We're talking about 50% survivals at 3 years. And this is important, and this gets replicated. This is a published TMH data. In our TMH data also, but there seems to be that these patients do well with systemic chemotherapy. The quality of life is also maintained. And if you see the toxicity part with this regimen, especially with gemcitabine, cisplatin, or this is from TMH data, so quite a few patients got taxane platinum also, is actually limited. So at present, the choice would be to use gemcitabine, cisplatin, because if you use multiple drugs, I think it shows that clearly that there is over one drug. We don't have good evidence of one chemo compared to the combination, but retrospective evidence seems to tend that overall survival is slightly higher when you go for a combination of drugs. Which drugs? I think the choice at present lies with gemcitabine and cisplatin. This is from TMH data also. We got tend to using paclitaxel and carboplatin, but there seems to be gemcitabine cisplatin. This curve is for gemcitabine cisplatin, seems to be do better than paclitaxel carboplatin. The next question comes is, how long do you want to give? The Zhang data gave 6 cycles of cisplatin 5 and gemcitabine cisplatin and stopped. Most of the data in nasopharynx, as opposed to what is in other head and neck cancers, actually stop after 6 cycles of therapy. We actually, Tata had a good database, and so we did this analysis. Some of our consultants used to stop after 6 cycles, some of used to continue. So we got this opportunity to see whether higher number of cycles, if the patient has tolerated, would improve. No, it didn't improve. It had absolutely similar. So on this state, I think it is unlikely that continuation of more cycles is beneficial. How would you follow up these patients of recurrence post-treatment? I think it's important that not only you do a symptom-directed imaging in this patient, you do a routine imaging in this patients so that you catch the recurrences early. See, this is not curve which is not published. What I've done, I have a photo image, the curve of PFS
of the zone study or with the overall survival. What you can see is that there's a big separation between the PFS and OS. What does that suggest? That suggests this is something like where your second line, third line therapies are giving you reasonable good things, and there are multiple options which these patients can be given. So it's important to catch these patients at early recurrences. So this is what the data was from the ZONG. Nearly, it was surprised to me that even in a trial setting, 60% of the patients at progression didn't got any treatment. 40% of the patients got treatment. So it's important that these are young patients most of the times. The bimodal peak here. So it's important that we focus on these patients and pay attention. So similar things goes in TMH data also. Only 46% get the second line, and the third line is got in around 55% of the patients. Do we get reasonably good outcomes when we give second line treatment? Yeah, the outcomes with multiple regimens seems to be reasonably good. If you look at the OS, those are between 12 to 13 months. If you remember, Amish sir was talking about TPEX giving us 12 months, 14 months. So this is second line we are going getting with single agent therapies. This and consistently in between 10 to 13 months has been the year. So I think it's important that there are multiple options in nasopharynx which we don't routinely discuss, and that's important. Another important options is this VEGF like TKIs here. Would see again, they tend to give outcomes of around 10 months oral survival. So you have oral therapy options like sunitinib, axitinib. Axitinib actually has much better data with respect to tolerance also, and which gives reasonably good survivals in these patients. What about immunotherapy? I told you that expressions of PD-L1 are pretty high here. We have some data from Keynote 208 with a subset of nasopharynx patients. Most of the patients had received multiple lines. You could see the 1/3 of the patients were post 5 lines of therapy. And let me repeat it again for the, it's post 5 lines. So 1/3 of the patient received immunotherapy after 5 lines of therapy. Till your response rates was 26%. And I'll tell you, most of us or medical oncology, there will be some non-medical, this kind of response rates after 4th line, 5th line, we don't get it. This is a table showing summary, which shows that, yeah, in multiple lines also, this actually multiple immunotherapy agents have been used. China has been the predominant force here. And so you would see carfilzolizumab, tocilizumab, tislelizumab being used. There's interesting data of phase 1 study which came from China where carfilzolizumab was combined with gemcitabine and cisplatin. The overall response rate, the sample is low, I know, but it is very exciting that the overall response rate in that situation was actually 91% and the 1-year PFS was 62%. So that is good. Yeah, there is data about randomized evidence whether you would put immunotherapy in second line. The pembrolizumab plus chemotherapy has not got yet reported. Keynote 122. Spalituzumab with chemotherapy has got reported. Though there seems to be better results with of OS with spalituzumab, this was actually a negative study. And this is a compilation. The red shows you the responses with immunotherapy in the first line setting. In the after first line, this can be multiple lines, and you see that there's consistent 20 to 30% response rates. In the first line setting, it's around 40 to 50%. If you combine it with chemotherapy, it goes up to around 90% responses. And yes, the responses are higher if you have higher PD-L1 expression, which is seen. Are trials going on? Trials are definitely going on this setting where we may see a change in first line therapy. What another interesting thing is, nasopharynx is a cancer of Taiwan, Singapore, China. I would love to see a day when we have like oral cancer trials where it is written India, India, India. Now, metronomic chemotherapy can be given. Oral cyclophosphamide has actually shown fantastic results with a median PFS of around 5 months. Again, this is multiple times treated patients. So this is another options which you have. Have we used methotrexate, celecoxib in this situation? We have, and it also gives you reasonable. This is used in post 3rd line therapy. So for recurrent and metastatic, gemcitabine and cisplatin remains a preferred option. Second line, there are multiple things to offer. Don't forget your multiple chemotherapies. Don't forget your oral TKIs. Don't forget your immunotherapy. Don't forget your metronomic chemotherapy. This is one cancer where I would say that you need to push things because these patients get a reasonably good survival. And the survival is as good as if you look at the
survival just shows of 33% at around 3 years. That's as good as locally advanced oral cancers when you do surgery. And this is just to justify why an NCCN says that if there is oligometastatic disease, we need to get our radiotherapy colleagues on board. There's good amount of data that if the patient is doing well on chemotherapy, has oligometastatic disease, addition of local treatment really benefits. Like for example, you can see here, if there is single site, this is in months, so 100 months, which will nearly 8 years, survival of 50%, similarly 8 years, survival of 40%. So it's important that we don't talk about this commonly, that in nasopharynx, recurrent and metastatic nasopharynx, we could do a good multidisciplinary discussion and get these patients. Last 5 minutes, I would just spend on talking about, we all know that if it is a locally advanced nasopharynx, T2N0M0 is a issue. NCCN says you may give concurrent or not give concurrent. The data is that from endemic regions of EBV, there are multiple analysis, small studies that suggest that probably adding chemotherapy in this situation doesn't benefit. There's counter data from Western series also, where addition of chemotherapy has shown to be benefit. So the divide is that in endemic, it would be reasonable to say in endemic region, probably giving chemotherapy in this situation may or may not benefit. In non-endemic region, it is more safe to say that addition of chemotherapy benefits. Now, whether RT, CT, sometimes Kaplan-Meier curves are deceptive, and that's the reason why I have made this graph. Look at with RT alone, the 3-year PFS, 22%. What you get with addition of chemotherapy. How much is the increment? You could see here, when it's 40 going to 70, we are nearly doubling the survivals. There's no question. CT-RT has to be the base in this situation. And another point, there will be some younger colleagues listening, students listening. See, for this amount of benefit also, when you do a meta-analysis, it's habit of saying that it is only 6.3%. Understand, when you do meta-analysis, whatever trials are there, all trials are going to be clubbed. Whether it's good quality, bad quality, whether platinum was used, whether inadequate doses were given, all trials are going to club. So it's important for to understand that when the meta-analysis says that this is the benefit, this is club of all, please go and read the meta-analysis to see the regimen which you choose, what benefit it has. Most of the times you would see that then the benefit starts tending to be seen over what was seen in pivotal trials. What we used, the ULSARAF data was RT versus RT plus chemotherapy followed by adjuvant chemotherapy or with cisplatin 5FU. I think there's enough data to say that neoadjuvant chemotherapy is important, and now it gets listed as the category 1 option with the NCCN guidelines and the preferred option, which shows that DCF in the doses of TAX-324, DCF in the doses of Sanyat University or gemcitabine regimen, there is benefit. There is a survival benefit which is seen with this using of neoadjuvant chemotherapy. So either DCF, either gemcitabine seems to be a good choice. The question is, what about adjuvant? Actually, NCCN recommends adjuvant. A few of my colleagues across the country also give adjuvant. If you ask my personal opinion, I would go with the Sanyat University paper, which was a large study of 400, in fact 500 patients, which shows that study was simple. CT-RT versus CT-RT plus adjuvant chemotherapy. For asking the specific question, does adjuvant chemotherapy benefit? Just to warn you, what they used in the adjuvant was cisplatin 5FU. So actually this shows that adjuvant of cisplatin 5FU probably does not add to survival. Whether TPF would add, whether gemcitabine cisplatin would add, we don't know. There is a study of 18 one-arm studies going in Sanyat University, trying gemcitabine, cisplatin as neoadjuvant, TPF as neoadjuvant, multiple other regimens as neoadjuvant or adjuvant, or a combination of both. I think that would give much better idea in this space what to do. But I think the time has come that we look at this data very seriously, which came in Lancet in July 2020 and was presented at ASCO. This study had both many patients who were post-neoadjuvant chemotherapy, CT-RT, also few patients who were post-CT-RT. What they did, observation versus maintenance metronomic for 1 year of capecitabine. It was clear that there was a survival advantage which was seen, and the advantage was seen at all aspects. So if you ask me what is our standard of care for at Tata, it would be neoadjuvant chemotherapy, followed by CT-RT, followed by post adverse events of CTID, we would prefer to give 1 year of maintenance with capecitabine. I have not covered radiation-related details, but it's important to say that this is one side in head and neck cancer, but intensive immunoradiotherapy is required. There's a survival advantage. There's a phase 3 randomized study to support it. This is one site in head and neck cancer where we have 100 versus 40 milligram per meter square has got compared, and 40 has been shown to be non-inferior to 100. This is another site in head and neck cancer where we have a randomized study of weekly cystatin compared against weekly carboplatin. And again, it has been shown that weekly carboplatin is as good as weekly cisplatin. And this becomes important because if you are giving neoadjuvant chemotherapy, we do a PTA routinely before pre-NSCT, post-NSCT, before CTID. If you see that there is a hearing loss with cisplatin, which has happened, so we safely change our sensitizer to carboplatin. With that, I will thank Vikas and the organizers for giving me this opportunity. Thank you.
Thank you, Dr. Vijay Patil sir, for such a clear and crisp talk on nasopharyngeal carcinomas. On the shortage of time, we move to, we have now 2 presentations. The first one, it's a pleasure to welcome and invite Dr. Sapna Nangia, ma'am. Hello, ma'am. Good evening. Ma'am is a senior consultant in radiation oncology, lead head and neck, breast and gynecological cancers at Apollo Proton Cancer Center, Chennai. Ma'am, over to you for your talk. And Madam is going to dwell on proton therapy for oral cavity and oropharyngeal cancer. Ma'am, over to you for your presentation, please.
Thank you very much. As I share my slides, I'd just like to thank Vikas for inviting me for this, really wonderful, invigorating meeting, and it's been a lot of learning. And thank you so much to the previous speakers. I want to know whether my slides are visible.
Yes, ma'am. Slides are visible, and you can start your presentation.
Okay. So I will be dwelling upon.
I'm sorry to interrupt. Can you make it on a full slideshow, please? Because there are multiple slides which we can see.
I'm so sorry. I'm so sorry. I just need to sort this one out. Has it become?
No, ma'am. You're going to slide 2, but we can see the. Can you share again, please? Yeah.
There is an option on the top, use slideshow. Please, on the top left corner, there is an option, use slideshow.
The third one, yes. Yeah. Excellent, ma'am. Yes, ma'am. Now we can see it. Yeah, please.
So as Vijay mentioned that, we really want to see more and more data about oral cavity cancers, which is what is relevant for us. And this is the preliminary data for oral cancers using proton therapy. Most of it is oral cancer. So of course, when we look at proton therapy and compare it with photon therapy for the non-radiation oncologists in the audience, if this white thing is the tumor, X-rays attenuate as we go along, as they travel along the path to the tumor and continue to travel even beyond the tumor. However, in proton therapy, it is possible for us to define exactly where the energy is going to be deposited, and no energy is deposited distally. Because the energy is being deposited in a very slim segment, there are multiple layers that are needed to treat the tumor. And so there are subsequent, smaller energies of protons, and then another smaller energy, and this is called the spread out Bragg peak. The Bragg being the person who had identified or who had described this phenomenon. Because the energy is not being deposited distal to the tumor, it is possible for us to spare normal tissues better. Because it is possible to spare normal tissues better, it is possible to dose escalate in certain situations. However, we have noted in our initial experience that there are other things that we can do when we are being able to spare normal structures better. And that is because dose escalation is really not so relevant in head and neck cancers. But acceleration of radiation is, and I believe that photon therapy is one domain where acceleration of treatment may become a possibility. Of course, because we are being able to spare normal tissues better, where it is difficult for us to treat normal tissues because of the proximity of neural structures like the visual pathway or the brainstem or the temporal lobes, such as paranasal sinus tumors or claviculomas, protons become very, very relevant. There is also a thought that because the radiation is being deposited in a very concentrated manner, there are more double strand breaks, and there is a possibility that radiobiology also plays a role, but we still need to confirm that. So this is a third generation of proton therapy machines that are now available. The earlier generations were called the passive scattering techniques, and then the scanning techniques. So this is the pencil beam scanning technique. This is the one that is currently available at the Apollo Proton Cancer Center. And you're seeing that there is a thin pencil of tissue of energy or of protons that travels and delivers radiation in a very conformal manner. Because you're talking about using a 3 millimeter beam, it is actually possible to conform to the shape of the tumor. And this is an advantage over the earlier techniques which involved the use of compensators and where proximally you could not spare as well. Here it's possible to conform the shape of the radiation to match the shape of the tumor. So why would we want to consider proton therapy for head and neck cancers? So we do know that there are so many critical organs that impact various functional domains, including, for example, the dose that is being delivered in the posterior fossa of the brain has been found to be allied with fatigue, or we may look at things like the hippocampus, which is something that we had presented last year, we had published last year, wherein for nasopharyngeal cancers, for oral cavity cancers, especially buccoalveolar complex cancers, hippocampal doses are of relevance. And so, yes, there are many critical organs. There is, of course, a potential for improvement in outcomes. And we as head and neck oncologists know that we are really stuck at a certain number when we are talking about definitive treatments. About a quarter of a patient will require retreatment. And it is important for us to optimize retreatment by ensuring that the first treatment is sparing as much tissue as possible. And I would like you to note this not in the context of the cost of proton therapy. Of course, the cost of proton therapy is what it is, but in future, when it is not as expensive it is right now, and I'm saying this because I've been through the cycle of when IMRT was introduced into the country. So at some point of time, this too becomes relevant, that we will be able to optimize retreatments by ensuring that the first treatment itself is sparing normal tissues as much as possible. And then there are special groups such as the elderly, young adults, and those with comorbidities. So of interest, and I'm sticking to definitive and post-op treatments and not discussing recurrent cancers here. Sinonasal cancers, adenoid cystic cancers, and especially oral cavity oropharyngeal cancers with reference to mucositis. My focus is primarily on the oral cavity oropharynx, and I'm just touching on the sinonasal cancers first to mention that our initial experience has been accepted for publication in JCRT, and we hope to have it online soon, where we have the first 6 patients who were treated. So the outcome in these 6 and then subsequently another 4 that we have treated has been excellent, and we've had only 1 patient recurring adenoid cystic carcinomas that involve the base of skull region because of the radiobiology and because of the ability of being able to give high doses of radiation in the proximity of critical structures. With adenoid cystic carcinoma, we have many retrospective studies showing, and the most recent study from PSI, PILAC et al. Is actually a 90%, 92% survival at 5 years. So there is definitely excellent outcomes when treating adenoid cystic carcinomas with proton therapy, and that has been our experience also. Sinonasal cancers are another area where we know that as compared to retrospective data of IMRT, which is in the range of about 60% or 62% local control at about 3 years. Consistently for PNS tumors, head and neck treated with proton therapy, the local control is in the range of upwards of 80 to 85%. Of course, diverse histologies, but even in patients who have undergone only biopsy, there is a 60% long-term control rate. So, of course, these are difficult tumors. And when we talk about optic apparatus, we have to remember that we are not only talking about retina, we are not talking only about optic apparatus, about the optic nerves and the chiasm, but actually the eye itself is very, very sensitive. And these, the structures around the paranasal sinuses include the lacrimal gland or cornea, very important, where keratitis can be an extremely debilitating condition, even leading to loss of vision. We know we now have constraints for the cornea, and we understand that if we restrict the maximum dose to around 38% or so, 38 gray or so, it's possible for us to prevent keratitis. Also, glaucoma, because of revascularization, is also a possibility. So therefore, restricting the dose to the globe in general is very, very important. So we've treated about 15 patients of various histologies, adenoid cystic carcinomas, alveolar. Recently, we treated a sinonasal teratocarcinoma. The results have actually been quite gratifying. And 2 out of these patients have failed. 2 out of these 15 patients have failed, but the remaining 13 remain disease-free at present. And this is one of our initial patients treated about 2 years ago, and she was recently in the OP 2 days ago. And this was her initial tumor presenting, encasing the optic nerve, leading to loss of vision in this eye. And also, actually, if you see in very close proximity to the optic apparatus on the other side, we had to have a discussion with her. She gave us consent only for loss of vision in one eye. And we used a combination of protons and photons in this. And as you can see here, the dose distribution, we were able to spare the contralateral optic nerve very efficiently. You can see how the chiasm is being spared and the optic apparatus nerve of the other side is being spared. And this was again an adenoid cystic carcinoma. We treated her with 70 grain, 35 fractions, and with concurrent chemo. And this was her visual field analysis before treatment, which means that on the right side, she had not been able to do a visual field analysis at all. And she recovered her vision, and that was really extremely gratifying. And even though we have treated 2 doses which are beyond the radiation tolerance of the optic nerve, the patient has regained vision and has maintained vision. Now, coming to the question of oropharyngeal cancer, from which we are extrapolating our information for oral cavity to some extent. So we do know that from retrospective data that when we compare the signs and symptoms of patients who have undergone proton therapy, they are likely to have better outcomes. And I'd like you to look at this at 12 months. Head and neck pain, xerostomia, moderate to severe dry mouth, and most importantly, the role function. The ability to go back to a normal life in 98% of patients who've undergone proton therapy versus about 79% of patients. So significant 20% difference in patients who undergo proton therapy. And that is because of better sparing of normal structures. And there's one particular normal structure that we are particularly interested in, and I will come to that. So again, we do know from retrospective analysis that patients who undergo proton therapy have lower incidence of PEG placement, less hospitalization, reduction in end of treatment narcotic use, reduced cough and better taste, report feeling less ill and better swallow. Interestingly, more mucosal infection has been noted by the provider, though less pain and less mucositis has been reported in this analysis. But more mucosal reactions have been noted. And that is primarily in the area of treatment. So if that means that it is indicating higher double-strand breaks or more intensity of treatment, that is something that we will learn over time. So we ourselves, this is in December 2021, we have treated 70 head and neck patients and 20 clival chordoma and chondrosarcomas of the base skull. And of these, the overwhelming number of patients are oral cavity patients. Of course, the next most common patients are nasopharyngeal and paranasal sinus tumors. And to highlight some of the possibilities that it allows us is this solitary plasmacytoma patient who had undergone surgery, who had basically a frontal bone orbit plasmacytoma. You can see the location, it was causing proptosis, and this is him at the end of treatment. The lesion having receded back, but most importantly, being able to treat this tumor very comfortably without causing keratitis was very, very gratifying. This is the dose distribution. You can see we made him look inferiorly, and that allowed us to give some space for our radiation treatment to be delivered. So as far as the patients are concerned, when we look at our radical intent patients, 43 patients, of which 18 have had de novo radiation and adjuvant has been in 25. So at a median survival of median of 13 months, 38 patients were alive with that's a 90.5% survival. But coming specifically, so is what I'd like you to note here is that the nasogastric tube requirement has been very, very minimal. So in 6 patients out of these 40, we required to put it, but only in week 6. And after completion of treatment in 2, most of these patients have been elderly. And the average NGT duration has actually been very much on the lower side at about 3 weeks. Unplanned treatment breaks, though in 46% of patients, but the average treatment break has been only 1.2 days. And most importantly, there has been no prolongation of overall treatment time. In fact, we follow a policy that we moderately accelerate the treatment, and in the latter half of the treatment, along with chemo, we are managing to give 6 fractions of radiation. So this is what we can achieve for recurrent tumors. This patient had received sinonasal radiation earlier, 10 years ago. We needed to retreat, but the focus is not really on recurrent tumors. The focus is discussing what we have been able to achieve. One of the things that we have evolved is, when we started off, these were the kind of skin reactions we were seeing, but we have been able to develop an algorithm which has allowed us to give to restrict our skin reactions, and I have to compliment our physics team on that, and the work that we did along with them has allowed us to limit the skin reactions, which have otherwise been an issue in proton therapy. We have also evolved strategies which are specific to our tumors. So we have done this analysis for a titanium plate, for example, and therefore only then taken up buccal mucosa patients. So we have put a phantom and made the phantom have a titanium plate. Similarly, we have designed various kinds of mouth bites which allow us to make sure that the proton is not ending on normal tissue. So this is a mouth bite that is actually pushing the tongue away. This is a mouth bite for a patient who had very poor mouth opening, and therefore you have Ryle's tubes that allow him to breathe. This is a patient for whom gaze fixation has been used to reduce the dose to the cornea. And similarly, in this patient, we have pulled up the lid and the eyebrow using these stitches that were placed by our surgical oncology colleagues. Or in a recurrent tumor treated in a left lateral position, right lateral position, because of the patient's inability to lie down flat. So inoperable tumors, of course, are of interest to us, but I can't say how good the results of proton therapy are going to be for oral cavity inoperable cancers, simply because our surgical team is quite aggressive, and we are very clear that we are willing to offer treatment for inoperable proton therapy tumors to genuinely inoperable oral cavity patients. So some of our results here, this young man, 38-year-old, as you can see, hard palate tumor extending into the ITF and the base of skull region, doing well 1.5 years post-treatment. These are his scans. Even his recent scan has been, even subsequent to this, when we have done MRIs, he remains well. And but the most important thing, I think, that the message that I would like to give is that mucosa, which is one organ at risk that we have not really addressed as much as we'd like to, simply because we were constrained by technology. So we see that oral mucosal doses, this is a work that has been done at Netherlands, where they believe very strongly in the model-based approach. And they have noted that oral mucosa doses are responsible for 12 side effects, including dysphagia, xerostomia, loss of taste, sticky saliva, etc., etc. So mucosal doses are one area where with proton therapy we have been able to make a difference, and that, I think, is the crux for us for oral cavity tumors, and that holds true both for buccal mucosa cancers as well as tongue lesions. So of course, that requires us to very importantly draw the oral mucosa in a reproducible manner. And for that, we have used proposals that have been made by Chris Nutting's team. And a lot of work has been done by many authors in that team, and we have followed that. And what you see here is the reduction. This is a dose volume histogram, and this shows a substantial reduction in, ranging almost to about a 30% reduction, as you can see in this patient with a tongue cancer. So this is a tumor, this is the proton plan. This is the photon plan. We are looking at the 57 gray and the 51 gray isodoses here. And we see here that there is a reduction in the dose that is possible as compared to a tomotherapy plan and a proton therapy plan. And this is the difference between the proton therapy and the tomotherapy plan. So the oral mucosa doses are substantially reduced by doing proton therapy. And this is another demonstration of this. As you can see, the oral mucosa is being spared here, and the oral mucosa is being spared here. And here we have used doses of 3200 and 3900, which again, from literature, from Narayan et al., we know that this is responsible for severe and mild mucositis. So we can, severity and duration of mucositis. So it is possible with proton therapy to reduce the mucosal doses. And this I'm saying on the basis of this analysis that we have done of 22 patients. What you will note here is that, as expected in oral cavity tumors, 70% of patients are receiving adjuvant radiation. There is no difference between the IMPT plan and the IMRT plan in coverage. So they are both non-significantly different. But what is different is the significant reduction in the oral mucosa doses, 20% reduction in the oral mucosa doses, but a 40% reduction in the dose received by the mucosa outside the PTV. And that, I think, is critical. So from 32 gray, we have been able to bring it down to 19 gray. And that is where I think the future will, the path that proton therapy will help us take for head and neck cancers. So we see now this is the dose levels at those points at various levels. So volume receiving 32 gray, 39 gray, related to the severity and the duration of radiation. Various other studies telling us that the 45 gray, 50 gray volumes are also important. So this is the normal oral mucosa. This is the spared oral mucosa. So as far as the spared oral mucosa is concerned, as you can see, a 40%, 50%, 49%, etc., reduction in the dose being received by the mucosa, translating into a reduction in the normal tissue complication probability. So the normal tissue complication probability for ipsilateral radiation, as we can see, has come down from 40 plus to about 22 or 23%. For bilateral radiation as well as unilateral radiation, we can see that there is a significant difference. Similarly, in oral cavity tumors, 40% versus 25%. Again, in oropharyngeal tumors, 38% versus 20%. So significant difference in the normal tissue complication probability. And another area which is of special interest to our group is a reduction in the dose being received by the elderly age group of patients, which I believe, so normally when we talk about proton therapy, we discuss young adults, but here we are discussing a different situation, and I will touch upon that briefly later. This is borne out.
Ma'am, sorry to interrupt, but last 5 minutes, ma'am, please.
Last, how many minutes?
5 minutes, 5 minutes.
Oh, fine, thanks. So, so even from literature, we see that, as I mentioned, between unilateral and bilateral radiation, or ipsilateral and bilateral radiation. So this is borne out by literature too. This is a group from New York, which has published where they have discussed 41 patients. Again, reduction in the dose to the oral cavity, very substantial. As you can see, 20 gray versus 0.6 gray, or 21 gray to the larynx versus 10 gray to the larynx, which results in a reduction in the risk of acute mucositis, nausea, dysgeusia, with a higher dermatitis risk with proton therapy, which I believe we have been able to address and which will be something that I will discuss later, another forum perhaps. So even in hypopharyngeal cancers, where traditionally there has been a question mark about whether proton therapy is useful or not, we have seen that there is a substantial, again, the dotted lines are the hypopharyngeal data, the helical tomotherapy data for midline mucosa, the entire midline mucosa, and the oral cavity. As we can see here, the dark pink is the midline mucosa, which means that it also includes the mucosa of the pharynx as well as the esophageal mucosa. Again, a very significant reduction in the low doses being received. And this is what we can see here in this comparison. The 50% isodose sparing the pharynx much better, even in this hypopharyngeal cancer patient. So I would like to mention here that this reduction in mucosal toxicity stresses the fact that not just for young adults, but across the spectrum. So even in elderly patients, except for this gentleman here, all the other patients are elderly. And as you can see, at the completion of treatment, their mucositis is actually near completion of treatment. Their mucositis is actually negligible. This person is receiving treatment for a PNS tumor, and you can see the mucosa on the contralateral side is spared very well, and that improves the tolerance of treatment. We have noted that most of our patients have been able to complete treatment, as I mentioned earlier, without increase in overall treatment time, which is a far cry from the planned breaks that we normally need to give elderly cancer patients. On the other hand, in young adults, we know we can reduce the risk of second cancers. And what you're seeing here, the 6 gray dose volume is related to the risk of having second cancers. So this is a young patient with a mucoepidermoid carcinoma involving the cheek. And what you can see here is the 6 gray dose cloud is the dark purple dose cloud with a helical tomotherapy plan versus the 6 gray isodose with a proton therapy plan. So much better sparing, not just of the mucosa, but also of the posterior fossa, reducing the risk of developing a second cancer in this young person. And finally, what proton therapy allows us to do, and this is something that has been published from MD Anderson, is that it allows a patient better employability after treatment. So absenteeism and composite work impairment have both been noted to be significantly less in patients undergoing proton therapy. There is also some presented data, not yet published, that the risk of subsequent treatments or the cost, overall cost, especially even in terms of treatment, is less. Subsequent treatments, emergency admissions, tube requirement I've already stressed, hospital admissions. So when we look at the composite sort of picture, at some point of time, I believe that the cost of proton therapy is not going to have as much a bearing And hopefully, the benefit of this technology will be accessible to more patients. I would like to acknowledge my team here. So this is our head and neck oncology team, the surgical oncology, medical oncology, dental and radiology, pathology people, our team of young radiation oncologists, Dr. Uppal, Dr. Nofal, and Mr. Mayur, who have helped us with the tomotherapy and proton plans. And good tomotherapy plans have been our impetus to improve our proton therapy plans. And finally, our team of physicists and technologists. Thank you very much for your attention.
So thank you so much, ma'am, for such a lovely presentation. Dr. Vikas, you are there. Any comments, anything from your side?
We feel totally privileged and humbled. Absolutely stunning piece of presentation, as I must say that a lot has come in terms of the surgery and chemotherapy, and similarly a lot has come in terms of the radiation also. So side effects do play a role in terms of radiation, and reducing those side effects and increasing the longevity, especially in head and neck cancer, is very, very important for these patients. A very enlightening talk, and I believe all those who are there would feel honored to have Dr. Sapna Nangia ma'am for the same. Thank you, Dr. Sapna ma'am.
Thank you, ma'am. So we move to the last part, and this is again a talk and the academic partners are BD. So we request Dr. Vikas to take up this talk on choosing the right CVAD while picking the fight with cancer. So over to you. Can we have Dr. Vikas slides, please?
Perfect. And it is very important that when we deliver these systemic therapies, as these therapies tend to have long-term implications. Though patients, those who are on long chemotherapies, they tend to have a lot of cycles going on, and with each subsequent cycles, the chances of thrombophlebitis, extravasation tends to increase, and they tend to cause a lot of disabling damages to the patients. And that's why choosing the right delivery of these chemotherapies is also very important. Next slide, please. So lack of venous access may always prevent the continuum of chemotherapy for our patients. Next slide. And as we give more and more subsequent and sequential therapies, second line, third line therapies, the accessibility of the venous is again issues. Next slide. And that's why we have to pick the fight with the cancer, with the best available devices that are available to us, because we know the chemotherapies are always notorious for phlebitis. Nearly 70% of our patients have those irritant chemotherapies going on, and extravasation tend to occur in quarter of these patients. And when these extravasation occurs, the compliance of these patients tends to decrease, and therefore it becomes imperative that with the subsequent deliveries, we tend to reduce the phlebitis and the extravasation of this. And nearly 33% of our patients do tend to have a difficult venous access in this. So therefore, choosing a right delivery access device is very, very important, especially in those patients who are on a long-term chemotherapies and are bound to be on these for a near future also. Next slide, please. So as we know, the various classifications of chemotherapies, we don't tend to recapitulate it, but all of these are either vesicants causing damage to the veins, or they are the irritants causing continuous irritations of the veins through which they are being delivered, and or either they are both of them, the vesicant and the imperative that we choose a delivery channel, and we can prevent this peripheral venous access device related complications by reducing the phlebitis, by reducing the extravasation, and by reducing the repeated venipunctures. Every patient who has a chemotherapy requires a pre-assessment investigations, and therefore the venipunctures are multiple. Phlebitis is notorious, and
That's why it is important that we tend to take this in very seriously. Next slide, please. The international guidelines do recommend that we should choose an appropriate catheter, which should be based on the type of the chemotherapies, the length of how much duration of the chemotherapies we are giving, the vascular integrity, and the length of the treatment. Anything which is these chemotherapies have a pH of less than 5 or more than 9 tends to precipitate. More than 600 milliosmolarities, they have a tendency to precipitate, and therefore whenever we require a long-term infusions up to 1 year, PICC is the treatment of the choice which should be offering to all of these patients. PICC, as we know, is a peripherally inserted central line. Next slide. PICC lines are recommended for administration of irritant and vesicant chemotherapies. We use this as non-peripherally compatible infusate chemotherapies regardless of the proposed durations. And the nurse should use the central venous access device to administer long and short-term chemotherapies, neoplastic agents, vesicants, irritants, parenteral nutritions, variety of antibiotics, and other medications, fit whatever the pH it is. And this has been consistent across all the protocols. Next. PICC ensures that the vascular complications are reduced as compared to the traditional chemotherapies. There is adverse events reduced, the bloodstream infections are reduced, significantly lower risk, toxicities, especially in hematological malignancies. The punctures, the number of the punctures are reduced, there is lower frequency of adverse events associated with the PICC removal also. Next slide, please. And when we tend to indwell them in long-term patients, it is intended, especially for those who are having multiple number of chemotherapies. The durability of this PICC ensures that it can be used up to 12 months. A PICC can be cited for lasting from few days to many years. PICC line can stay in your arm for at least 12 months. And any patient you are planning chemotherapies, vesicants, irritants should have an indwelling PICC line before the initiation of it. Next slide, please. The Grosjean PICC has a superior performance as compared to the other, in the terms of it reduces the reflex blood clotting. Whenever the PICC is a external device and the hematological system has a tendency to form clots against it. With the valve design inside the PICC, the Grosjean, it reduces the blood reflex clotting. It controls the flow of fluid for the superior infusion chemotherapy by its 3-wave valve. With the weekly maintenance, just a single saline flush, not even a heparin flush, a single saline flush reduces the maintenance cost, allows for the clamp-free infusion therapy. So there is always a clamping sequences which were with the earlier PICCs, but with the Grosjean PICC, the clamp is also not there. It's a very easily grippable winged lock solution. The connector is simple, enhanced extensions so that we can have multiple therapies simultaneously being going on. And very important is the StatLock catheter for the stabilization with it. It is we can have a single lumen Grosjean PICC or we can have a double lumen Grosjean PIF. Double lumen is only for increasing the durability. Both the lumens are of equal caliber, so any type of fluid can be given through any of these catheters. So even the blood and the antibiotic infusions. It also has a reverse taper design which strengthens the external portion of the catheter and tamponates the bleeding at the insertion site. Next slide, please. The 3-wave distal valve design has a valve that opens inwards, which allows the patient for the blood aspiration. So you can have your normal blood investigations easily with it. The positive pressure allows the valve to open outside, allowing whatever the infusions you are giving to directly deliver to the blood. And the neutral pressure, the valve remains closed. So it reduces the risk of the air embolism, reduces the risk of blood risk and clotting, and eliminates the confusion of clamping sequence, reduces the need for an anticoagulation heparin, and therefore it is a closed system as compared to the open lines, the central lines which we have. This is a closed system which helps its superior performance with a proven effectiveness. Next slide, please. With the closed system catheter, you have a lesser vascular complications, the longer dwell time, the reduces venous punctures, and improved DVT management also. So we have a PICC that ensures the continuum of chemotherapy continues. Next slide. And the compliance of the patient increases. And that's where they have a very important continuum of care courses, which includes the online courses, the workshop, and the patient guidance for these patients. Next slide, please. Also, it is building ecosystem across for choosing centers of excellence. There are live workshops with external experts. The insertion training is always there, give on hands-on with this, and the PICC insertions are carried out across India. Next slide, please. Next slide. So when you have to pick a fight with the cancer, you have to choose the right delivery device, and Gauchon catheters are the one which are having a superior performance and ensures the delivery of the chemotherapy and also the compliance of the patient, and prevents the extravasation, phlebitis, and other complications, and therefore they are recommended across the chemotherapies. That brings to the end of the talk and also the end of the conference. I would sincerely like to thank from the bottom of my heart to every faculty, every moderator, every panelist, every speaker who has come, especially in this cold, chilly Sunday morning, and has contributed to building this conference a successful conference. Also would like to thank all the sponsors who have contributed to make this conference a successful one, and the Team Horizon for continuing a proper management throughout the conference. And all the participants who have watched and learned diligently throughout this whole meeting, wish to continue this meeting further on next year onwards. So looking forward, thank you everybody.
So thank you so very much, Dr. Vikasa, for those kind words. Thanks everyone who joined, from all of us on the organizing team, my colleagues Aru and Palak. We say thank you, goodbye, stay safe, and a lovely evening. Thank you so much from all of us. Stay blessed.